अच्छा लगता है ऐसा।
हाँ, सही में।
ये अच्छा है, कम से कम है ना। एक लाइवलीनेस आ जाती है, ऐसा लगता है सामने बैठ के बातें कर रहे हैं।
सामने बैठ। करेक्ट करेक्ट।
सब
सुनो,
पूछे चल।
शेयर शेयर करके फिर कहाँ जाना है?
खुशी।
व्हाट्सएप में जाऊं?
नहीं नहीं, मैं कर दूंगी नीलम।
हाँ।
बस शेयर करके, बस नीचे से आपको अपना उठा लेना है पीपीटी।
हाँ। नहीं, शेयर का बटन दबा के और पीपीटी। ये।
फिर उस पे एक डमरू जैसा बना हुआ है ना ये साइड में, मतलब कप जैसा। उस पे कर
हम्म।
लो तो स्लाइड शो पे आ जाएगा।
अरे वो तो शेयर नहीं हुआ ना अभी।
अभी तो शेयर ही नहीं हुआ दीदी। या तो इसने को होस्ट नहीं बनाया आपको।
ठहर, मैं 2 मिनट रुक, मैं शेयर करती हूँ।
अच्छा।
देखती हूँ मेरा शेयर हो रहा है क्या।
चल नीचे जा रही हूँ।
देखते।
आप
मैं
मंगा
देखती
लो,
हूँ
ऑलरेडी
आपको
दो
को होस्ट
मंगाए।
बनाया हुआ है क्या। आपको हो बना रखा है दीदी, को होस्ट तो हो जाओगे, आप कर लोगे।
अच्छा। नहीं, मैं शेयर का बटन दबा के उसके बाद इस पे चले जाऊं ना जहाँ पे पीपीटी है।
हाँ, पीपीटी को क्लिक कर लो, हाँ। नहीं दिख रहा दीदी, पीपीटी पे क्लिक किया आपने।
1 मिनट कर रही।
हम्म। हाय अंजू मैम, कैसे हैं।
आया क्या?
नहीं।
पीपीटी पे आ गई शेयर।
पहले तो नीचे से ग्रीन कलर का बटन दबाओ, एक शेयर का है।
नीलम, पीपीटी को पहले ओपन करके रखना अपने लैपटॉप पर।
हाँ। हाँ, ये कर लिया और ऊपर
डेस्कटॉप पे
शेयर का
मिनिमाइज
बटन।
कर दो। डेस्कटॉप पे मिनिमाइज कर दो। हाय
अच्छा।
मैम, पीछे से इतनी सुंदर फोटो दिख रही है आपकी। हाँ अब आ रहा है दीदी, हाँ।
आ गया।
अभी आप करो,
हाँ।
अभी नहीं आया, हाँ अब
अब इसमें पीपीटी को करो क्लिक।
अभी आपका ये व्हाट्सएप चल गया दीदी।
नहीं, मैंने
आपका
शेयर।
व्हाट्सएप दिख रहा है।
अच्छा अच्छा। शेयर। ये व्हाट्सएप हो गया, ओपन किया इसको।
ऐसे नहीं।
आया क्या?
हाँ। अब ये डमरू बना हुआ है ना नीचे ये इस टाइप का एक जार जैसा, कप जैसा। यहाँ पर एक नीचे हाँ यहाँ पे आओ, हाँ इसको इस पे करो क्लिक, हाँ इस पे कर दो, हाँ। हम्म। अब ये
आया।
इसको स्क्रीन पे, हाँ हाँ दिख रहा है। अब आप इसको
हम्म।
ऊपर नीचे करके देखो, चल रही है क्या स्क्रीन। हाँ आ
हाँ,
रही है, आ रही है, आ रहा है, आ रहा है, आ रहा है।
तो स्टॉप शेयर कर दूं?
हाँ
हाँ
स्टॉप
कर
शेयर करके
लेना।
इसको मिनिमाइज करके नीचे रख लो।
मैं भी एक बार शेयर करके देख लेती हूँ, तो स्टॉप शेयर
हाँ।
कर ले।
हाय संगीता दीदी, आप भी शेयर करना चाहते हो अपनी
हाँ,
स्लाइड।
अभी
एक
करती है,
बार
अभी
आप
करती है,
ट्राई
हाँ।
कर लो।
अरे इसको बाहर बांधना पड़ेगा। हाय एवरीवन। अभी तो
हेलो
अंजू सर
मैम।
भी है।
मैम वो
मोनिका।
सिर्फ डॉट 6 o'clock पे ज्वाइन करेंगे।
अच्छा अच्छा अच्छा,
सर
ठीक है ठीक
बिल्कुल
है।
डॉट 6 पे ज्वाइन करते हैं।
हाँ हाँ
क्योंकि शायद उनकी पहले कोई चल रही होती है उससे।
ये भी मैं इसमें हूँ।
हम्म।
इसमें कौन सा चाबी है बताओ मम्मी जी।
हाँ आपकी आ रही है दीदी, हाँ आपका आ गया। हम्म। हाँ दीदी आ गया। हाँ संगीता दीदी अब आप कर लो।
शेयर हुआ क्या?
हाँ एक बार आया था। अब
हेलो।
आपका
पर
ये
अब
जूम का हटाओ। ये जूम का हटा दो। हाँ ये हटा दो, आ गया, इमोटिव्स आ गया। अब नीचे आपका एक वो होगा उसको, हाँ ये अब चल रहा है। हाँ। हाँ। अब आप इसको फुल स्क्रीन कर लो थोड़ा सा। हाँ सही है। ठीक है।
अभी फुल स्क्रीन नहीं हुआ संगीता।
एक बार यहाँ पर एक है ना वो, उसका बटन है लास्ट में।
हो गया फुल स्क्रीन।
अब तुम्हारा ये मेरे ख्याल से वो स्मॉल हो रखा है, उसको बड़ा कर लो
अरे
सर।
नहीं, फुल स्क्रीन है, मुझे तो फुल दिख रहा है। हेलो।
हाँ अंजू दीदी।
ठीक है,
मुझे तो फुल दिख रहा है डियर।
ओके
हाँ बिल्कुल फुल
ठीक
है
है,
अभी।
अब
ओके।
फुल है। एक्चुअली चारों तरफ क्या है कि ब्लैक है, इसलिए ऐसा लग रहा था।
नहीं, उसका
हाँ
वो स्क्रीन बड़ा नहीं करा हुआ।
ठीक है, ये भी चल जाएगा।
नहीं ये स्लाइड शो में नहीं है, ये है
हाँ दीदी, स्लाइड शो करके देखो।
नेक्स्ट स्लाइड।
हाँ चल रही है ना स्लाइड, चल तो रही
हाँ
है।
फर्स्ट क्लास चल रही है, फर्स्ट क्लास चल रही है।
हाँ दीदी 10-15 मिनट्स की रखना टॉक।
स्टॉप शेयर कर दो।
हाँ
इतनी सारी स्लाइड 10 मिनट में कैसे होंगी?
15 मिनट्स में, मैंने कहा था शॉर्ट कर रखना। हाय दीपिका,
Hi,
हाउ आर यू?
hi, good
सीइंग
evening,
यू
good
आफ्टर अ
evening.
लॉन्ग टाइम।
Yeah, hi, hello. Hi, Dr. Neelam. Hi,
हाय डॉक्टर दीपिका, हाउ आर यू?
हाय हाय दीपिका।
Hi, hello, ma'am. Hello, Dr. Taru, ma'am.
हेलो,
मुझे डायरेक्टली
मुझे दे, हाँ हाँ मुझे कर दीजिए। हाँ ओके।
मैं
रितु
क्या
भी आ गई।
डॉक्टर दीपिका खूब काम कर रहे हो।
हाँ, कुछ चल रहा है।
दिखता रहता है एनआईजीएफ में।
हाँ,
Seeing lot
NIGF
of
में,
us.
हाँ। अभी
Good.
हमारा संडे को भी था। वी मिस डॉक्टर तरु मैम, मैम नहीं आई। डॉक्टर वीना आचार्य मैम भी नहीं आई। मैम बिजी हो गई आई थिंक।
हाँ, वहाँ पे बहुत अच्छा हुआ है। हाय।
यस मैम, हम आपको आपके लिए वेट करते रहे। अब हम आपको चंडीगढ़ में
हाँ,
देंगे।
मिस
आपके
किया।
लिए चीजें बननी पड़ी है।
एक्चुअली मैंने मिस किया तुम सबको।
यस मैम, वी मिस्ड यू एंड डॉक्टर वीना मैम के उनका तो लास्ट में भी गेस्ट ऑफ ऑनर और सबका सब चीजें बनी हुई हुई थी ऑल द। तो अब ये हम आपको चंडीगढ़ में मिलेंगे मैम सब।
चंडीगढ़ में दे देना मुझे।
यस मैम, बिल्कुल बिल्कुल। डॉक्टर दिव्या ले गई है, बोला कि मैं चंडीगढ़ में सब दूंगी।
दिव्या से हमने पहले तय कर लिया कि चंडीगढ़ में दे देना।
यस मैम बिल्कुल। तो आपकी ब्रेस्ट कमेटी के बहुत लोग आए हुए थे, डॉक्टर ली
हाँ, वो
और
मैंने देख लिया था। बीना दी थी
यस वीना,
और निभा तो थी ही,
मैं
एंड
इसको
वो
शेयर कहाँ से
प्रिया भी
खोलूंगी?
थी।
डॉक्टर सविता त्यागी भी थी।
सविता त्यागी भी थी।
हाँ जी।
और वो थी, क्या
डॉक्टर
कहते हैं,
सर्वेश्वरी नौटियाल,
सर्वेश्वरी जी थी।
डॉक्टर
हाँ,
राधिका रतूरी, ये सब बाहर से।
राधिका रतूड़ी तो वहीं से ही है।
हाँ
सर्वेश्वरी जी, हाँ।
हाँ, देहरादून से आए थे। हाँ जी।
हेलो, नमस्ते मैम, तनु मैम।
नमस्ते, कैसे हो?
मैं अच्छी हूँ, आप कैसे हो? बहुत
एकदम
समय बाद।
बढ़िया।
जी, आप भरतपुर
अंजू जी
आइए मैम।
नमस्ते। हाय
मैं आ
मधुलिका।
रही हूँ तुम्हारे भरतपुर। संगीता।
हाँ मैम, नमस्ते मैम, नमस्ते मैम, आइए मैम, मोस्ट वेलकम, मोस्ट वेलकम मैम।
संगीता अच्छी है?
हाँ मैम, अच्छी हूँ, एकदम बढ़िया मैम।
Ma'am, it's past 6 o'clock. Please let me know whenever we want to start the session.
नीना मैम नमस्ते।
Hello. Ma'am, am I audible?
Yeah, we can hear you.
Okay.
Has sir joined, Doctor?
सर इज जस्ट ज्वाइनिंग, आई कॉल्ड हिम।
ओके ओके, तो
अब
फिर
बहुत दिन हो गए तो शायद सर भूल गए कि ज्वाइन भी करना है सर को भी।
सर अभी कर लेंगे सर। 2 मिनट और रुक जाते हैं ना।
हाँ हाँ,
हाँ,
हेलो डॉक्टर मोनिका, कैसे हो?
बस बढ़िया है, आप बताइए।
तुमने स्पीकर बना दिया मुझे।
अच्छी बात है ना, अपने राजस्थान वाले सब आगे आए। मैं तो यही चाहती हूँ कि ना अपन कुछ कुछ करके जो लोग है ना बोल सकते हैं वो बोले, ताकि एक बार 2 बार फिर अगली बार वो ऑर्गेनाइज कराने में रहे, हमें ही बुलाए।
यस बिल्कुल। डॉक्टर मोनिका उमरडन ज्वाइन करेंगे आज?
वो इमरजेंसी में है तो शी माइट नॉट बी ज्वाइनिंग।
ठीक है, आप
आई विल स्टार्ट द
संगीता
प्रोग्राम।
तो दिख रही नहीं है फोटो में।
हाँ, एंड आई बी
संगीता
डूइंग
is
द
not
फर्स्ट
seen.
सेशन ना डॉक्टर मोनिका। मेरा फर्स्ट सेशन
हाँ
ये
फर्स्ट सेशन
है।
ही आपका।
हाँ, एंड उनको बुलाना ना डॉक्टर उनको।
हाँ
हाँ
नम्रता।
हाँ, नम्रता को। यस हाँ।
मैं देखती हूँ कितने जनों ने ज्वाइन कर लिया।
हेलो मोनिका।
हाय।
हेलो।
मैंने तो
हाँ
दीदी
मैम।
आपको इतना हेलो करा था, पर आप सब में बिजी थे तो आपको जैसे हायरार्की वाइज ना मेरा नंबर आया लास्ट में।
नहीं
अच्छा,
ऐसा
मोनिका
कुछ
हैज
नहीं।
ज्वाइंड।
हेलो
Yes.
हेलो
पटेल सर
नीलम।
है ज्वाइन। हाँ सर।
सर
सर चालू करिए।
हाँ
गुड
चलो।
इवनिंग सर, गुड इवनिंग सर।
गुड इवनिंग, गुड इवनिंग,
गुड इवनिंग सर।
गुड
गुड
इवनिंग सर।
इवनिंग, गुड इवनिंग।
आपका वीडियो बन गई
सब बिलेटेड हैप्पी
नमस्ते
बर्थडे।
सर, बिलेटेड हैप्पी बर्थडे टू
यस
यू।
सर,
थैंक
सबके
यू,
लिए हैप्पी
थैंक यू,
बर्थडे विशेस टू सर।
थैंक यू।
सर आज सेलिब्रेशन होना चाहिए।
बिल्कुल।
टेक टीम
आप
कैन यू प्लीज लेट अस नो व्हेन वी आर
आप
लाइव।
सबके हाथ
दीदी
में है।
We are
दीदी
live, ma'am.
है
Can
ना,
we
अब तो
proceed?
सर स्विगी से भी भिजवा सकते हैं अपने यहाँ एक एक पैकेट।
A very warm welcome to all the esteemed faculty members and the delegates who have joined us today for the Happy Learning Masterclass webinar series. Today's episode is on postpartum hemorrhage, which every gynecologist dreads. Today's episode is in association with Bharatpur, Hanumangarh, Jaipur, Sri Ganganagar, Pali and Sikar societies. We welcome all the presidents and secretaries and the joining delegates who have joined us today. This Happy Learning Masterclass webinar was a mastermind of Dr. MC Patel sir, and we have started this since the time of COVID as an academic exchange so that every nook and corner of India has the academic knowledge. Now, before we begin, let us take the blessings of Lord Almighty. The tech team, can we have the inauguration slide, please? Thank you for the inauguration. It is my proud privilege to introduce Dr. MC Patel, sir, the Program Director of the Happy Learning webinar series. Sir is your candidate for Foxy presidential election. He has been the Vice President of Foxy. He has also been the past President of the IMA Ahmedabad, the Red Cross, the National President of NMO, and Organizing Chairperson of the Vivekanand NMO. Sir has been actively serving under the Dhanvantri Seva Yatra since the last 23 years in Jammu, Kashmir, and in the northeastern districts. He is an important medical legal consultant across pan-India and the go-to person in case if any gynecologist has a problem. Sir has also been the Honorary Secretary of the SOGOG and the Organizing Chairperson of the VPCon in 2018. Sir, we welcome you and we request you to please deliver your welcome address for the webinar.
Thank you,
Good
Monica.
evening, MC Patel, sir.
Yes,
And
good
belated
evening,
happy
ma'am.
birthday, sir.
Yeah, thank you, madam. Thank you. So it gives me immense pleasure to welcome you all to this 243rd episode of Happy Learning Masterclass. And just mention today's joining society from Rajasthan, Bharatpur, Hanumangarh, Jaipur, Sri Ganganagar, Pali, and Shekhawati Society of Sikar. I welcome Dr. Veena Acharya Madam. She has kindly consented to be chief guest to bless the webinar. She is always with me. Whenever I have called her, she has simply told, yes, I am there with you. So welcome, madam. And thank you for sparing time for me to bless this webinar. I also welcome two learned guest of honor, Dr. Ritu Joshi, past Vice President of Foxy, and Dr. Anju Soni, sitting Vice President of Foxy. I also
Good evening,
welcome,
everyone.
Yes, welcome, Ritu.
Thank you, sir.
I also welcome learned chairperson Dr. Namrata Bansal from Hanumangarh, Dr. Prerna Rathod from Hanumangarh, Dr. Sarita Upneja from Sri Ganganagar, and they are going to chair very important session of emotive approach in PPH, and it will be delivered by Dr. Sangeeta Agarwal Madam from Bharatpur. I also
Good evening, sir. Good evening.
Welcome, madam.
Dr. Namrata this side.
Welcome. I also welcome one more set of chairperson, Dr. Savita Lalgiria Madam from Sri Ganganagar, Dr. Sarita Punia, Dr. Sivcharan Meena from Pali, and they are going to chair one important session of surgical management of PPH, and it will be dealt with by Dr. Sapna Kaswan Madam from Sikar. I also welcome one more set of chairperson, Dr. Ritu Gupta from Bharatpur, Dr. Anil Goyal from Bharatpur, and Dr. Sarika Gupta from Bharatpur, and they will be chairing session of legal issues in obstetric hemorrhage, which will be dealt with me only. I also welcome two learned moderator, Dr. Taru Chaya Bansal Madam from Jaipur and Nilam Jain from Jaipur. They are going to moderate very interesting panel as far as today's topic is concerned. And two experts will be there to have their expert opinion during panel discussion. Dr. Sushma Sethia Madam and Dr. Madhulika Agarwal Madam from Jaipur. I also welcome all the learned panelists, Dr. Richa Gupta from Bharatpur, Dr. Nidhi Gupta from Jaipur, Dr. Ashok Neniwal from Pali, Dr. Renu Sethia from Hanumangarh, Dr. Bial Rao from Sikar, Manju Singh Madam from Bharatpur, Dr. Sarmila Atolia and Dr. Indira Lamba Madam from Jaipur. In era of COVID-19, I started this series with 2-3 friends, and at that time when physical meetings were not possible, my goal was to just say hello to our Foxian friends on virtual ground to discuss any focused topic and to be useful to our Foxian friends in their day-to-day practice. But ultimate goal was to check maternal mortality and infant mortality, because by 2030, Government of India and WHO has given us a target that maternal mortality should be less than 70 and infant mortality should be less than 12. So with this aim, we are discussing focus topics which are useful in our day-to-day practice. And as far as this target of less than 70 MMR by 2030 is concerned, it is possible with joint hand with government, federation like FOXI, IMA, and our obstetrician friends, particularly who are working in rural India and delivering with all obstetric cases. So if we go join hand and meticulously, if we can manage our patient, then we can check maternal mortality and achieve the target. So with this, we are discussing focus topic and to be helpful our Foxian friends, not to end up into medical legal problem. And if at all, then how to deal with, how to get rid of it is our goal. I also welcome my team, Dr. Monica Umberden, convener for this series, Dr. Monica Gupta, Dr. Deepika Logani, Dr. Satabdi, Dr. Niyotita, and Dr. Megha. They are coordinator for this series. Some special record as far
Can
as
I request Dr.
efforts on
Sarita to
part of
please mute?
Monica Gupta is concerned. She has helped me a lot for this particular webinar, not only designing, but to execution of this webinar also. So thank you, Monica Gupta, for the same. And all the president and secretary of Joining Society and all the delegates who have joined this webinar. So welcoming you all again. Over to you, Dr. Monica, for further proceeding. Thank you very much.
Thank you, sir, and we wish you all the very best for the forthcoming elections. And we request all the people from joining societies to please support sir in his candidature. And it is my privilege to introduce our chief guest, Dr. Veena Acharya, Madam. Madam is a senior consultant and head of the department on preventive oncologist at the Rajasthan Hospital, Jaipur. She has been the chairperson of the Indian College of Maternal and Child Health, NARCHI, India, president of the Rajasthan branch of NARCHI, patron of Association of Gynae Endoscopy Surgeons of Rajasthan, the National Executive Member of ISCCP and Director of the Colposcopy Center and National Executive ISCCP. She has been also awarded the Chikitsa Vibhushan Award on Doctor's Day in 2018, received an Appreciation Award by FOXI in Postgraduate CME. She has been invited as a faculty at Prince of Songla University at Thailand and invited international faculty at the Global Summit of Maternal and Child Healthcare. Madam, we welcome you and it is an honor to share the stage with you. We request you to please share your words of blessings with us.
Very good evening to all. I'm really thankful to Dr. MC Patel Sahab and Dr. Monica for inviting me on such an important webinar on PPA. The time matters. Really, it is a very need of ours. Postpartum hemorrhage, as we all know, continues to be one of the leading cause of preventable maternal mortality worldwide, including the India. The tragedy is that many of these deaths occur within the few hours after the delivery, and are largely preventable through the timely recognition, prompt intervention, teamwork, and the preparation before we know that this is going to be happen. As a physician, we all know that PPH occur every minute is countable. Delay in diagnosis, delay in mobilize the resource, delay in blood replacement, or delay in surgical intervention can make the difference between the life and death. I am particularly happy that today's program is addressed PPH in multidisciplinary. I think so. It is prepared by Dr. MC Patel Sam, because it is such everything's covered in this today's PPH webinar. The emotive aspects, what is the bundle, and the surgical management, legal implications, and the panel discussion on saving the mother's lives, innovation, and the best practice PPH care. The comprehensive approach reflect the reality of the clinical practice where the successful management require not only the knowledge and skills, but also the comprehensive coordination and the documentation for the legal issues. And Dr. MC Patel always says, save the life of the patient, but save yourself also by completely documenting. That is a very important part of the management of the patient. The theme of PPH time management is highly relevant. I would like to add 3 more things in this: recognize early, act early, and save the mothers. These 3 things when we are doing the time management. I congratulate Dr. MC Patel Saab and the organizer for bringing together all the eminent speakers, especially Dr. MC Patel Saab. Also, one of the part, Dr. Sangeeta Agrawal, Dr. Sapna, the moderator for the panel, Dr. Taru Chhaya and Dr. Neelam Jain, all will from the different part of the different region of the country. Such academic intervention help us to translate the evidence into the practice and ultimately improve the maternal outcome. I wish this webinar is a great success. Look forward for the high deliberations and interaction in between, and it is really benefit for the physician and the trainers and healthcare team workers across the India. I'm sure this deliberation, and I'm also that our 2 guest speakers are the renowned, knowledgeable, eminent, and they will also input in between that Dr. Ritu Joshi and Dr. Anju Soni, that how it will be very fruitful. All the best wishes, Dr. MC Patel Saab, for your future, and we are with you. All the Rajasthan, all the societies, we have from my bottom of the heart, I wish you for your success. Thank you so much.
Thank you, madam, for sparing time for us.
My pleasure, sir. My pleasure. I'm always with you.
Thank you so much, ma'am, for being with us today. It is always a constant encouragement that all seniors provide us. And I would now request Dr. Monica Gupta, madam, to please introduce our guest of honor, Dr. Ritu Joshi, madam, and Dr. Anju Soni, ma'am.
Thank you, MC Patel, sir, and Monica for giving me opportunity to organize a webinar with the Rajasthan people. All our familiar faces, I feel at home, like we are chit-chatting in our own space. And I'm very thankful to everyone who has joined and has come on my request over here. And it's my proud privilege to introduce Dr. Ritu Joshi, ma'am. She's a past vice president. She was a chairperson, Family Welfare Committee in 9 to 12, faculty in various national and international conferences, contributed various chapters in the books, and editor for the books on contraception. And she has presented numerous papers and posters in national and international conferences. She's awarded.
Thanks, Monica. Enough. Thanks, Monica.
Madam, and you are the most important thing. You are running an NGO for the girls from 6 to 15 years and for their education. And that is what the need of the time is there. We have to educate our girls so that they can bring a better future. Over to you, madam, for your blessings.
Thanks. I'm really grateful to all of you for inviting me on this forum. And I know that MC Patel sir has been running it since years and years and years, I would put it now as. And I think he is one of the best candidates we could have, to become the president of FOGSI, who knows FOGSI very well. So friends, we must look into this issue, but today's webinar is very interesting. We all are very well aware. And as NHS 6 also tells us that the maternal mortality, the main cause happens to be hemorrhage. And that is also pregnancy related. So as once upon a time, Muhammad Fatala said, that women are not dying because of the disease we cannot treat, but they are dying because societies have yet to make the decision that their lives are worth saving. And this is where our role comes as obstetricians. I always feel that, every patient of mine is going to have a PPH. So if I'm aware of that then I work in that lines and try and save the patient, because we work on all those checkpoints and our checklists in which we are trying to prevent the PPH in our patient. So I always think that she might land up. I don't look around for the risk factors or anything, because even a normal delivery, we can land up in a PPH. So the other important point for the PPH happens to be the anemia, and we are working towards, anemia Mukt Bharat. So both the things are very, very important for us, and I'm proud and privileged to be on this forum today. Thank you very much.
Thank you, Dr. Ritu. You are always with me in any of my academic activity. Thank
Yes,
you
sir,
being with us.
always. Thank you, sir.
Thank you, ma'am, for your blessings. You are always with me and with the all the activities we do. And we are very thankful that you have given your precious time for this. And our next
Thanks,
guest
Monica.
of honor is Dr. Anju Soni, ma'am. She's a current vice president from the West Zone. She was the IMS president before, and she was a vice president JOGS also. She has hold enormous posts into the Foxy, into the Jaipur OBGY Society, Menopause, and she's a very renowned figure in Rajasthan. And she's always humble and helpful and ever smiling. And moreover, her beautiful dressing sense always inspire all of the gynecologists to be dressed like her. Over to you, madam. And you have got n number of awards and n number of activities. Up to your credit, you have done excellent work into the HIV committee, and still as a vice president you are doing everything. And one day we wish we will conduct such type of webinar for you when you will be contesting for the president election. Over to you, madam, for your blessings.
Thank you, Monica. I want to thank one second. I want to thank first both Monicas who are here today. Both of you are stars in your own way. It is very, very hearty to be here today in this webinar where Dr. MC Patel is conducting this beautiful webinar, and I want to give him my best wishes in the beginning only, because I know we have been close for years together, and he has been more than family to all of us. And I'm very happy, Monica, that you have involved the Rajasthan society like Bharatpur, Sri Ganganagar, Jaipur, and Mangarh. And all these people from Rajasthan, they are very, very actively working. And today's academic whole is so well planned, and it has been, I'm sure the academic excellence which has been there today will definitely help everyone. We have all gathered here today not to just discuss PPH condition, but understand why it matters globally. It still remains the leading cause of deaths in worldwide, and each life lost is a reminder of importance of vigilance, preparedness, and timely action. And this occurs in the cases where we do not think that PPH is going to occur. That is the most important point. So we should be prepared for preventing PPH in each and every patient. And today I'm sure we will know the guidelines of PPH. They provide us a clear evidence-based steps that empower healthcare providers to recognize early warning signs, act decisively, save lives, and following guidelines ensures that every mother has the last chance of a safe delivery. And no matter where she is in the world, because every drop counts, every mother matters, and preparedness is the difference between life and death, life and loss. And we must learn and every day and relearn the art of saving our mothers through PPH drills, which WHO has also come out recently with all the guidelines So we must know what are those guidelines and how we can save each and every mother in the golden hour, understand how much is the blood loss, how to measure the blood loss, and when to act. Thank you very much. And best wishes again to Dr. MC Patel sir for his future venture. Thank you,
Thank you.
everybody.
Thank you, Anju Madam, for sparing time for us.
Thank you everyone for being here, and I request from Rajasthan we all should vote and support for the sir. He is the most deserving candidate for the president elections. And when
Yes.
Veena ma'am has said yes, so definitely whole of the Rajasthan will vote for you, sir. Over to
Thank
Deepika
you.
for-
Yeah. Yeah. Thank you, Monica ma'am. Sir, with your permission, can we move ahead
Oh
with the
yes,
academic session?
oh yes.
Yeah. Deepika ma'am, we invite you to please conduct the session first.
So, yeah, thank you. So, thank you and good evening, everyone. At the outset, I would like to thank Dr. MC Patel, sir, Dr. Monica, both Dr. Monicas for giving me this opportunity. And now, with your permission, sir, we are starting with the scientific session. And the topic for the first session is emotive approach in PPH. And it is now my proud privilege to introduce our esteemed chairperson for this session. Can we have the CVs, please? Yeah. Can we move further? I think ma'am, Dr. Sangeeta, ma'am, you have started sharing the screen, I think.
Yes, ma'am.
Ma'am,
Should I stop?
yeah, please, because the tech team has to show the yes. So thank you. So we invite our first chairperson for the session, Dr. Namrata Bansal ma'am. Ma'am is the secretary of the Hanumangarh Obs and Gynae Society and is a senior consultant at Bhatinda Surgical Hospital at her town. Ma'am has received several recognitions for her contribution to women's healthcare, including the Chikitsa Vibhushan Award from the Health Minister, Government of Rajasthan. We welcome you, ma'am. Our next chairperson for the session is Dr. Prerna Rathod, ma'am. Ma'am is the past secretary of the Hanumangarh Obs and Gynae Society and has also served as the secretary of IMA Hanumangarh branch, an alumni of SP Medical College, Bikaner. Ma'am is the director and owner of Mahavir Hospital and Maternity Center at Hanumangarh, which she established more than 2 decades ago. And ma'am, we are delighted to have you with us and we extend to you a warm welcome, ma'am. Our next chairperson for this session is Dr. Sarita Upneja, ma'am. Ma'am is the president of Shri Ganganagar Obs and Gynae Society. Ma'am is also an alumni of SP Medical College, Bikaner, and worked in the as Punjab Civil Services Medical Officer and has been running the Shakuntala Nursing Home at Shri Ganganagar for nearly 3 decades. Ma'am, we welcome you. And now with the chairpersons in place, could I request Dr. Namrata Bansal ma'am to kindly introduce our speaker for the first session, Dr. Sangeeta Agarwal, and take the session forward. Thank you,
ma'am. Sure.
Thank you.
Good evening, everyone. Good evening, my respected senior faculty members, esteemed speakers, and dear colleagues. It is an honor and privilege for me to chair today's session on postpartum hemorrhage, a topic that remains highly relevant to every practicing obstetrician. PPH continues to be one of the leading causes of maternal mortality, and we need continuous updating ourselves, our knowledge and skills. That is very essential for improving maternal outcomes. So to enlighten us on this important subject, we are privileged to have with us Dr. Sangeeta Agarwal ma'am today as a speaker. Ma'am is the owner of Bharatpur Nursing Home and she is running successfully her center for the last 35 years. So she has vast experience in obstetrics and gynecology. Her special interest has been high-risk pregnancy, gynecology, and problems of infertility. Apart from this, she is a good social worker. So now I invite Dr. Sangeeta Agarwal ma'am. Ma'am, stage is all yours, but you have virtual platform is all yours. Ma'am, please deliver.
Thank you, Dr. Norda, for kind introduction. My good evening to everyone. My warm regards to Dr. MC Patel sir, Dr. Monica, and Dr. Vinacharya ma'am, Dr. Ritu Joshi ma'am, Dr. Anju Soni ma'am. Without wasting time, I am starting my session and my topic is emotives. Am I
Yes, ma'am.
audible?
Yes, ma'am, you're audible
Yes,
and we
ma'am.
can see your slides. Ma'am, बस full screen कर दीजिए. Yes.
वो देखना पड़ेगा ना यहाँ पे. Change कैसे करूँ? मैं करूँ. Okay. Now I'm starting. Today my topic is E motives, and E motives means evidence, monitoring, oxytocin, training, intervention, vigilance, equity, and system. It is a framework designed to drive zero preventable maternal death from postpartum hemorrhage. It is integrating clinical excellence with systemic accountability. When a baby born and mother loses her life due to PPH, it is very panic because she is a mother. She is not just a patient. She is a mother, a daughter, a wife, and her life hangs by the thread. This is a very panic paradox when a baby comes and she loses her own. Postpartum hemorrhage. It is a serious life-threatening ops emergency that has consistently remained the leading cause of maternal morbidity and mortality, both in the developing and developed countries. Despite advances in ops care, its burden remains unacceptably high across all healthcare settings. It is a global burden. It affects all women across all income settings and geographies. It is time critical. Rapid iteration demands immediate protocol-driven response, and it is largely preventable. It is evidence-based intervention can avert the majority of PPH death. Definition of PPH. In vaginal delivery, when blood loss is more than 500 ml within the first 24 hours of delivery, and in cesarean delivery, when more than 1 liter blood loss within first 24 hours of the delivery, cesarean. And a clinical threshold is any blood loss that threatens hemodynamic stability regardless of volume measured. And according to WHO definition, it is same in the means of volume. Causes of PPH. It is due to tone, trauma, tissue, and thrombin. So uterine atony is the most common cause of the PPH. It accounts for 70% of all the PPH. This is the most common and most preventable cause also. Second is trauma. Genital tract laceration, uterine rupture, or surgical injury during delivery is the second cause. Third is tissue, retained products of the conception, preventing adequate uterine contraction. Fourth is thrombin, pre-existing or acquired coagulopathies, which impairs the body hemostatic response. Common consequences of PPH are hypovolemic shock, which causes DIC, which causes renal and hepatic failure, which causes ARDS, adult respiratory distress syndrome from systemic inflammatory response, which causes maternal death due to devastating and irreversible final consequences of uncontrolled hemorrhage. PPH is the leading cause of maternal death. It causes 35% of maternal death of all maternal deaths worldwide. Its incidence is 11% in globally, and it causes 50% of death within 24 hours. On half of all maternal death from PPH occur within first 24 hours. It is, and 40% of death are at level 1 facilities. This is painful truth about PPH related maternal death. It is a leading cause of maternal death, as we know. 3% of all vaginal deliveries, even with appropriate management. Its incidence is globally in 11%. 40% dies at first level facility, clinics and district hospital, and 50% of maternal death occurs within 24 hours. And it is preventable. 54 to 93% are preventable when standardized multidisciplinary programs are implemented and consequently across all level of care. 70% mother lost every year. It is more in low and middle income countries where resources and protocols are least available. Our aim is zero preventable death from PPH. It is a global health strategy to reduce maternal mortality from PPH to zero through prompt evidence-based care delivered at every level of the system. Or it can be prevented by closing the gaps. Over 90% of the PPH mortality cases are linked to 3 critical failures. By deaths are mostly due to delayed recognition of hemorrhage, delayed or inadequate treatment, or insufficient resources at the point of care. All these points are preventable and treatable. Challenges in the management of the PPH, in the form of estimation of blood loss, we are not giving sequential care. We are giving simultaneous care, and by using inconsistent protocol use. If we are properly estimate blood loss, we give simultaneous care and sequential care and consistent protocol use. The deaths are preventable. The overriding priority is stop the bleeding, act before coagulation fails, prevent organ damage, and escalate without hesitation. Prevention should be at every level of the care. The E-motive bundle of care, precision should be within 15 minutes. We have to, we should not be panicked by seeing PPH. We should be precised and having protocol and purposeful action. We will act within 15 minutes. It represents the more powerful implementation tool available in turn the tide on preventable maternal death. There is a 15-minute window, which is time critical activation of the full bundle. And it is evidence-based and global impact is there. We have PPH bundle. In PPH bundle, it is active management of third stage of labor. First of all, call for help. And we should, we have to start IV fluids, uterotonics, injection tranexamic acid, and uterine massage. And we have to give supportive treatment also, give tissue repair and empty bladder and evacuate uterus. And response to refractory PPH in the form of aortic decompression, uterine ballooning, and anti-shock treatment. And we also give supportive treatment measure like in the form of blood and blood components, and we have to refer patient at the before damage. Critical use for early detection are objective measurement of blood loss with abnormal hemodynamic sign, which are if pulse rate is more than 100, shock index is more than 1, systemic blood pressure is less than 100 millimeter or diastolic less than 60, and objective blood loss more than 500 ml, whichever occurs within first 24 hours after birth, with particular vigilance during the first 2 hours after the birth. The emotive intervention by the calibrated drape, it is a drape which quantitative blood collection drape enabling objective early detection of PPH. It replaces unreliable visual estimation. And we have to work according to WHO first response bundle in the form of uterine massage, oxytocin drug, oxytocin, tranexamic acid, IV fluid, systemic examination, and a structured escalation protocol. And we have to implement support. Am I audible?
Yes, ma'am. You are audible.
Okay. We have to detect and treat postpartum hemorrhage early. In the E-motive mein, E means early detection and trigger criteria. In trigger criteria are clinical judgment, blood loss more than 100 ml or 500 ml, and blood loss 300 ml or more plus one abnormal observation. M for uterine massage, which is for 1 minute or till uterus contract. O for oxytocin drugs in the form of 10 international unit IM or IV in 200 ml to 500 ml crystalloid within 10 minutes, plus 20 international oxytocin diluted in 1 liter of the saline over 4 hours. And we add in this misoprostol tablet 800 milligram per rectally or sublingually if used. And we can give injection tranexamic acid 1 gram IV in 100 or 200 ml crystalloid over 10 minutes. And IV fluid support should be there. And we have to examine and escalate patient, ensure bladder is empty, clots in the uterus is not present, internal examination of placenta for completeness. And we escalate in bleeding does not stop. After first response or we are unable to identify to manage, we have to shift the patient. Usual care versus emotives. Difference in between usual care or emotive. In usual care, we are having visual estimation, and this is non-standardized provider dependent response, delayed recognition of hemorrhage threshold, inconsistent use of uterotonic agents, and no structured escalation pathway. In emotive intervention, this calibrated drape for quantitative blood measurement. It is a standardized WHO first response bundle triggered at threshold, and we have to immediate uterine massage plus oxytocin plus tranexamic acid, and IV fluid resuscitation protocol is also there, and structured examination escalation process. Risk assessment tool for PPH. We are having 3 groups in low risk, medium risk, and high risk. In low risk, there was no previous uterine incision, single pregnancy, no medical disorder, no non-bleeding disorder, no history of PPH, and optimal hemoglobin. In medium risk groups are patients are those which have which have induction of liver with oxytocin or cervical ripening, multiple gestation, more than 4 previous vaginal birth, prior cesarean birth or prior uterine incision, large uterine fibroid, history of 1 previous PPH, family history of in first degree relatives who experienced with PPH, or known or unknown etiology with possible coagulopathy, and there is history of there is a coagulomatitis, fetal demise, or polyhydramnios. In high risk group has 2 or more medium risk factors, active bleeding is more than bloody show, suspected placenta accreta or percudita, placenta previa, low lying placenta, known coagulopathy, history of more than 1 previous PPH, hematocrit is less than 30 and other risk factors, and platelet is less than 1 lakh per millimeter of cube. So we have to attend patient according to this group and take action immediately. Clinical features to suspect PPH. Finding of PPH when uterus is relaxed and flabby, then we have to probable diagnosis atonic PPH. When it is contracted with bleeding, then traumatic PPH. When undelivered placenta or partial expression of placenta tissue or incomplete placenta, then our probable diagnosis is partial or total retained placenta, non-palpable fundus of the uterus, then inversion of the uterus, and contracted uterus along with absence of trauma or retained placental tissue or failure of medical treatment, then our probable diagnosis is DIC, disseminated intravascular coagulation. Stages of hemorrhagic shock. There are 4 stages. Stage 1, stage 2, stage 3, stage 4. According to blood loss in percentage, blood loss in centimeter square, according to pulse rate, respiratory rate, blood pressure, and mental state. These are 4 stages of hemorrhagic shock. We have to treat according to this. Shock index is a vital tool for predicting the severity of hemodynamic instability. When shock index means heart rate upon systolic blood pressure. When it is less than 0.9, then monitor closely. When it is 0.9 to 1.1, likely moderate shock start transfusion. Modified shock index in this pulse rate upon mean arterial pressure, which is the normal range of this is 0.5 to 0.7 in healthy adults. If less in mean arterial pressure, we will calculate it by diastolic pressure plus 1/3 of the systolic minus diastolic. When it is 0.5 to 0.7, it is normal, or less than in 0.6, no shock. 0.6 more than 0.6 to less than 1, it is mild shock. More than 1 to less than 1.5 is a moderate shock, and when which is more than equal to 1.5 or more than this, it is severe shock. MOT bundle for postpartum hemorrhage. E for evaluate, assess for the risk factor and active bleeding. M for monitor, quantify blood loss and vital signs. O for organize, activate team and emergency protocol. T for treat, administer uterine tonics and intervention, uterotonics and interventions. E for investigate, identify source and escalate care. V for verify, confirm hemostasis and stabilization. How to perform uterine massage? By single hand and by bimanual abdominal examination. This is a picture showing uterine massage. Who can perform uterine massage? Skilled birth attendants, trained personnel, and qualified practitioners. Evidence-based oxytocin drugs for PPH. According to FIGO recommendation for management of PPH in 2022, uterotonics are considered the first line treatment for uterine atony. IV uterotonics done intervention oxytocin done in is the recommended first line uterotonic drug for treatment of PPH. When IV oxytocin is not available, or if the bleeding does not respond to the oxytocin, the use of the additional drug we can do, like intramuscular ergometrin, oxytocin ergometrin fixed dose, injectable prostaglandin, or misoprostol are recommended. PPH prevention and management, FOXI updated PPH guideline, this is same. Oxytocin we have to use 20 to 40 international in 1 liter normal saline, infuse 500 ml over 10 minutes, then 250 ml per hour. Then we can add prostaglandin if patient not responding, and we can add methylmergen to ampule IM, or we can or every 2 to 4 hours we can start it. And we can add misoprostol tablet 800 to 1000 microgram rectally or 600 to 800 microgram sublingually or orally. Tranexamic acid, we can use tranexamic acid. It is synthetic analog of the amino acid lysine. It inhibits fibrinolysis by reducing the binding of plasminogen and tissue plasminogen activator to fibrin. A PPH needs an IVSS with 2 wide bore cannula gauge 14 to 16 immediately. 14 is orange color, 16 is gray color. Isotonic crystalloid solution are preferred to colloids. Urgent venipuncture 20 ml for, and we have to start with the same time we have to do investigation, blood group and screen for full blood count, coagulation screen including fibrinogen, and we have to examine pulse, respiratory rate, blood pressure recording every 15 minutes and commence warm crystalloid infusion. IV fluid in PPH, what and how? Fluid replacement strategy is, fluid replacement is the crucial component of PPH treatment, and though dilutional coagulopathy may occur with a large volume of crystalloid, colloid or red cell are used with insufficient transfusion of fresh frozen plasma and platelets. Traditional volume limits are up to 2 liters of the warm isotonic crystalloid administered are as rapidly as possible. Additional 1.5 liter of the warm colloid if blood not available. Total maximum 3.5 liter fluid while awaiting compatible packed cells. IV fluid, we can administer rapidly. Speed of the fluid delivery takes priority over fluid type selection. Fluid should be pre-warm all fluids to prevent hypothermia and acidosis, and the patient warming should be there to prevent to maintain core body temperature. Emotive bundle framework. Examine thorough assessment should be there. Measure blood loss quantification. Oxytocin use first line utrotoxin, tranexamic acid, antifibrinolytic, infuse fluid resuscitation, and escalate the refractory cases and refer timely. Escalate when to act. Failure to control bleeding, bleeding persistent despite of initial intervention, unclear etiology, health provider unable to identify cause of the bleeding, and management complexity. Cases require advanced expertise or resources. Escalate the sixth component, evacuate bladder, evacuate clots, examine genital tract, and examine placenta. 3 key emergency intervention, manual uterine compression, external aortic decompression, and non-pneumatic anti-shock garments. Thank you. Thank you very much for patience hearing.
Thank you, ma'am. I would request the chairpersons to please give their inputs for this wonderful section on emotive, medical management of postpartum hemorrhage.
Thank you so much, Agrawal madam, for your excellent presentation. Thank you, Monica ma'am, for conducting a good webinar. It is really enriching.
Dr. Sarita, you want to say something? Sarita ma'am? Ma'am, please unmute yourself. Ma'am, unmute yourself.
Thank you, Monica, for giving me this this is ये मेरे लिए बहुत अच्छा आप लोगों ने किया जो मेरे को चेयरपर्सन बनाया, लेकिन हम लोगों को जब ये देखना है कि अगर हमारे पास केस बाहर से रेफर्ड होता है तो हमें उसको कैसे मैनेज करना है, उसके हमने 10-15 पॉइंट बना के और उसको फॉलो करना है। और सबसे पहले जब भी पीपीएच होता है तो उसका कलर देखना होता है। अगर 2 घंटे बाद उसका कलर बिल्कुल रेड से ब्लैक हो जाता है तो उसका मतलब जो पीपीएच है वो नॉर्मल हो रहा है और यूट्रस वेल कॉन्ट्रैक्टेड है। उसके बाद हमें कोई टेंशन नहीं लेनी है। सबसे पहले कलर और जो ब्लड का है ना उस पर ध्यान करना है अगर एटोनिक पीपीएच है तो। और मोनिका, जैसे कि आपको पता है कि मैं गई हुई थी तो इसलिए अभी मैं आज सुबह से मुझे डायरिया हो रहा था तो अभी मैं उठी हूँ बस। थैंक यू।
थैंक यू सरिता मैम फॉर बीइंग विद अस। तबीयत खराब होने के बावजूद भी आप हमारे साथ हैं। और मैम आप म्यूट हो गई हैं। सरिता मैम आप म्यूटेड हैं।
Thank you, ma'am, for being with us. You are always with us. Whenever I ask for your help, you are always there for me. Thank you very much.
Thank you, Dr. Sangeeta, and thank you, Dr. Chairpersons. Moving on to the second session. After medical management, there will still be some cases which need to be managed surgically. And to chair this excellent session on surgical management of postpartum hemorrhage, we have with us Dr. Savita Lalbharia. She is a senior obstetrician and gynecologist with 25 years of serving humanity and mankind, the director of Lalgaria Hospital at Sri Ganganagar. She has exclusive skills in dealing with all critical cases and OBS and with good outcomes. A good sonologist dealing with infertility patients, even including IUI, IVF, and gynae cosmetic aesthetics reconstructive surgery. Now, she's a member of Fetal Medicine Society and the secretary of Sri Ganganagar OBS and Gynae Society. She's also the IMA Female Wing President with a number of awards by Giant International Prerna Group and award by Lions Club and many more social welfare groups. The next chairperson on this for this session is Dr. Sarita Punia, a very senior gynecologist, and she's a laparoscopic surgeon with 25 plus years of experience in private practice and expertise in minimally invasive gynecological surgery, faculty at various national, regional, and state conferences, and speaker of CME's workshops and academic programs, including healthcare. The next speaker is Dr. Shivcharan Meena. He is the assistant professor at Government Medical College, Pali, Rajasthan, with special awards and achievements, with publications in international journals, with also IJCCR, also another publication on knowledge, attitude, and practices about contraceptives among reproductive age females, and a clinical study of intrathecal ketamine with adrenaline and adrenaline surgeries. I would request any of the chairpersons to please introduce the speaker for today, gynecologist and infertility specialist, Dr. Sapna Kaswan.
Dr. Savita is there. Dr. Savita can introduce.
Dr. Savita ma'am, could you please introduce Dr. Sapna Kaswan?
Savita, you are unmuted.
Yes, ma'am. Dr. Sapna Kaswan. Ma'am is gynecologist at Noble Care Hospital, Sikar, Rajasthan. She is executive committee member and No Violence Against Women Committee. Ma'am is executive committee member of IFS Rajasthan chapter in 2026 to 28. Nice to meet you, ma'am. Over to you, ma'am.
Thank you.
Over to you, Sapna, for your talk on the surgical management of PPH.
We'll be starting with the surgical management of PPH. Am I audible?
Yes, yes.
Yes, ma'am.
I would request the team to start with the slides, and I would request them to start the presentation with directly slide number 18. This I'm saying because previously in the previous one we have already discussed about PPH. Can I have the team member and the slide from slide 18 of the presentation?
You are not sharing your slide by yourself?
No, ma'am, it's not possible from my side.
Okay.
Can the team do it for me?
Have you shared your slides with them? Sapna, have you shared your slides?
No, ma'am.
Okay. Then I will share the...
While ma'am is sharing the slide, we'll be talking about the surgical management of PPH. We know that the PPH can, we grade the blood loss, and as per that we called it mild, moderate, and severe. When it is between 500 ml to 1 liter of blood loss, we call it mild. When it is more than 1 liter, we call it moderate. In this way, the classification of PPH is done. In the previous presentation, we have seen the type of PPH, the T's and all that had been this. This would be, in this presentation, we will be specifically talking about the surgical management of PPH. The most common thing and the first step when we are saying about when the medical management has been done, the first step we always tell is about the bimanual compression of the uterus. That we know we have to do it when we place one of the hand in the vagina and the other hand goes abdominally and compresses the uterus. This compression of uterus helps in the compression of veins and prevent the blood loss. Next, the one of the most important thing comes up to be are the different types of tamponade. We'll be getting the slide.
but by the time the team is coordinating, I'm just going verbally informing you about that. Now, the first step, we have done the bimanual compression, and the next option that is available for us are the different type of tamponades that are available. One of the most common tamponade that we know is of the Bakri balloon that is available for us. It is actually made of a silicon, 100% silicon, and it is said the use of it has a success rate of almost 88% to 90%. We can place that tamponade for minimum 8 hours and extend its placement for almost 48 hours. What it is done is the balloon is either placed through vaginally, through cervical opening, or if we are doing a cesarean section and we are facing a PPH, we can introduce it through the lower uterine scar. We place the balloon, we inflate it with around 500 ml of normal saline. The purpose or the action of working of the Bakri balloon is that when it expands, it compresses the veins and prevents the PPH. Then there's an outlet through which the blood that is collected in the uterine cavity is expelled out. So one is very common available, and that is Bakri balloon. The other is Sphingosine Blackmore. That is presently not much in a use, but it is actually used in the surgical management when there is a massive hemorrhage in cases of esophageal or gastric varices. So the other option occurs to be that. Ma'am, we are having the slides? Okay.
Share for you, Sapna?
Yeah,
Okay.
ma'am. Just tell the team to share for me and to start from slide number 18 itself, because all the previous slide before has been discussed by Dr. Sangeeta ma'am. Now PPH is like
the team member is not there. Team member, can you share the slides? I've set the slides on the group, or should I share for her? Tag team.
Now PPH is the biggest nightmare for every obstetrician. How much we are prepared for it?
Can you see the slides? Can you see the
Yeah, ma'am.
slides?
Yes, Dr. Monica.
Ma'am, from slide 18 itself.
You just tell me where to stop. I
18,
can't.
ma'am, 18 number. You can't see the numbers? Yeah.
No. Uterine packing. Which slide?
Then previous 3 slides. Previous 3.
You just tell me to stop.
One more.
Okay. Here?
Yeah, ma'am. From here. So we were talking about uterine balloon tamponade. One where I've told you about Sphingosine Blackmore tube. It was actually used in esophageal or gastric varices when there is massive hemorrhage. The one that is available for us is Bakri balloon, and it is literally like a God's blessing for most of us who are practicing in periphery. And then the other option is called to be as Shivka's pack. Next slide, ma'am. That is, yeah, ma'am, that's it. Then there is mask, that is the military anti-shock trousers. What are these? These are inflatable pneumatic suits. They envelop the legs and the abdomen. This controls the hypotension that is being there because of PPH, and it improves the perfusion of blood to the vital organs, and it slows the bleeding. Yes, this is the picture we are showing it about, and it is talking about the compression that is on abdomen as well as the legs. Next slide. Now the most important are the uterine compression sutures. The one that we are very familiar with is the Wheelan suture. It involves the lower uterine incision. To check, first of all, we'll check that the uterine cavity, it is empty. There are no blood clots and nothing. And then we would apply the brace sutures to the uterus. And this we do by transfixing the interior and posterior uterine walls. Next slide. We can see these are very beautiful slides. If you can appreciate it, that the suture, the first suture starts from the anterior surface. And if you could see that from the lower uterine segment below the scar, it starts, then we enter the uterine cavity behind the incision that we have done, and from anterior to posterior it would go. And from posterior part, this again enters, the suture again enters. And then a pictorial diagram has been very good talking about it. The purpose of it is that when we ensure the suture, it gives a compression to the uterus. Yes, the pictorial, and the most common one that is being used by most of us is this. This helps in the uterine compression. Yes, ma'am. The other option are Heyman suture. Heyman suture are nothing. It was in a way a modification of B-Lynch only, and over here 2 vertical sutures are placed over effectively, sewing the anterior and the posterior together. And one in these, Heyman suture. These are in a way of modification where individual suturing is done. 2 suturing is done for anterior and posterior wall, and one is for the cervico-ischemic part. Yeah, here we can appreciate these are the modifications that were given by we've seen the B-Lynch. Heyman and his colleagues introduced the modification of B-Lynch itself, where either you can put individual anterior posterior compression and a transverse compression in the lower uterine segment, or all of it is sutured, and then the aim for any of the sutures is to provide uterine compression. And while placing a suture, it ensures that the compression remains for a long duration. Next. Now there are Cho sutures. Cho sutures are called as multiple box sutures. They are multiple square sutures to approximate the anterior and the posterior uterine wall, especially in the areas of heavy bleeding. If we are able to appreciate that there is being profuse bleeding, then we put multiple square sutures are being put. Yeah, you can appreciate over here. Individually they are done. Then there is option of Pereira suture. Now Pereira sutures were, you can take it that on all the previous suturing, we have seen that the penetration of suture has been so that it enters the uterine cavity. Like all the layers of myometrium we have taken in the suture. In Pereira sutures, these are superficial sutures itself. And they are like an intermittent suture being placed in the layer, where you can see anterior and posterior approximation is done. And in the 3 or 4 layers, as per the condition, the transverse sutures are given. So multiple sutures opposed longitudinal and transversely in case of Pereira sutures. Yes. Next, ma'am. Hakutel. Hakutel were like a difference, not a difference. The main aim always being the uterine compression. Here we use 6 to almost 16 horizontal interrupted U sutures. Like individually the U sutures are being placed. Yes, we can appreciate that here we individually are placing every sutures, and there are multiple. It doesn't specify that it has to be 6 or 16. As per the flabby condition of the uterus, you can put multiple sutures, but these are individual sutures. And in the end, the picture of the compressed uterus would look like. Can we have the next slide, ma'am? Yeah, this is how it would look. And yeah, Cunningham sutures were also here. You can appreciate that there are multiple sutures done in the case of severe postpartum, in the case of severe PPH. These are transverse. Then there are Cuba sutures also. 4 sutures are placed on the uterus, where one is transverse suture in the middle of the fundus, one is in the lower side, and 2 laterally, if you could appreciate. Yeah, the picture makes it very clear to it. You can see we have put the lower uterine incision, we have sutured the lower uterine incision. Then we would put 2 transverse sutures. One would go above the incision, mid fundal or in the midline, to be precise, in the mid of the uterus. One, below our lower uterine segment, it would take care of the cervicoisthmus region, and two, at the, if you could see in the fundal region, they have been placed. Now, their Nelson sutures, it is a sandwich technique with concomitant use, like B-Lynch along with a Bakri balloon are called as Nelson sutures. Now, one of the most important part and the savior that comes. Actually, if you've reached to this level, you know that it has turned into a high-risk case. But this is something that every surgeon or every gynecologist should know it. That is the stepwise devascularization. Now, stepwise devascularization is actually a 5-step surgical progression. Like why we call it is a 5-step, like you start from below to up, you are going it. No, ma'am, we'll keep this, Monica, ma'am. I'll be explaining it in my own way. We'll keep this slide for a few minutes and I'll let you know when to change. So we'll be talking about stepwise devascularization. Now, the stepwise devascularization is actually a 5-step method. The first is we'll go for a unilateral uterine artery ligation. The aim of the first step is that it would restrict the blood flow to the most accessible site. Immediately, the action would be that the blood going to the uterus would be restricted and the PPH would be controlled. If unilateral uterine artery ligation is not sufficient, then we would go for the bilateral, that is the contralateral side of it is. This is said to be almost 80 to 90% effective in controlling the PPH. Now, if we have done the bilateral uterine artery ligation and we still feel that the PPH has not been controlled, then the target remains for the lower uterine artery or the cervico-vaginal ligation. In the picture, you can see, if you will be able to zoom and see the C part that has been shown, we would go for it. Now, the cervico-vaginal branches and anastomosis continue. We have to remember that the cervico-vaginal ligation is important because the cervico-vaginal branches and anastomosis, they continue to supply the lower uterine segment. So, just by doing uterine artery ligation, be it unilateral or bilateral, there might be chances the PPH has not controlled to the level we seek for. So the third step being, we know that we will go for the C part. You can see if over here, we would go for low uterine artery or cervico-vaginal ligation. Now then the other step that comes for is the unilateral ovarian vessel ligation. That is, it would, the step now remains that since we have ligated the uterine arteries, the main supply has been cut. Cervico-vaginal, the collaterals. The ovarian vessel ligation is depriving the uterus from the retrograde or the collateral blood supply. And if in any case the unilateral has not been helping us, we'll go for bilateral ovarian ligation. Now the last step and the saving grace. Like we call it a saving grace surgically because if it is not controlled by this, then we know what we have to see and we would not be able to save the uterus. So the last step in the surgical management remains to be the internal iliac artery ligation. Now we have to look for the conditions that are indicating for ligation. If the atonic uterus has been refracted to other measures, like we've gone for the sutures, any one technique of sutures, be it B-Lynch, Cunningham's, or any suture. If there's a abruptio placentae with uterine atony, then in this case, or there has been an abdominal pregnancy with pelvic implantation to placenta and placenta accreta. Here the anatomical picture has been very clearly shown. We can appreciate it from the aorta. From aorta, we can see the common iliac arteries there. and then there could be the extension of it being the external iliac artery and the anterior division of internal iliac artery. Yes, there's again a picturization of it. Now, how does it work? It controls the bleeding by converting the arterial system pulse pressure by 85% into venous system if bilaterally ligated. Unilateral ligation decreases pulse pressure by 77%. Blood flow distal to the point of ligation is decreased by only 48%. Thus, the reproductive function is preserved. Collaterals open within 7 to 8 minutes and blood flow is completely established in 45 minutes. Now, the step that we all dread and none of us would ever wanted to have it in our life and to see a patient to that step. That when all our suture methods, internal iliac ligation has still not been able to control because PPH cannot be only set for one reason. All the sutures that we have applied, they acquire or they control the atonicity. We have to remember. But we should never forget all the T's that have been there. And that clotting factors or any derangement in clotting factors can lead to any amount of surgical suturing being done insufficient to control a PPH. In this case, the last step in our hand remains to be the surgical step of proceeding for an obstetrical hysterectomy. Now, what are the emergency? If it is a case of ruptured uterus, if there is a uterine pathology, like there are fibroids or vascular tensions are there, vascular lesions are there, or any anatomical anomalies leading to hemorrhage, if there's an atonic PPH, if the patient has gone in DIC, if there has been a case of chorioamnionitis, if there have been perforating mole or choriocarcinoma or cobular uterus that we can see. In these cases, it is. Now, it could be elective when we elective in a way that we are mentally prepared for it, as it could be seen in the cases of a placenta eccrita or percreta. So, if it is a morbidly adherent placenta, and in the previous USG scan, we have a notion about it that we might have to take the extensive step, and it is always in today's time very good to take a consent. For if a patient, definitely a patient of percreta, eccrita is to be taken for surgical and cesarean cases. If it is taken, a separate consent has to be taken, and the patient should be informed that in case of severity, the options of obstetric hysterectomies would be there. So, in cases of elective, it could be like morbidly adherent placenta. In cases of CA cervix, CA ovary, or as methods of sterilization. Like elective, I would only quote for the morbidly adherent placenta. Next, ma'am. Now, how does it differ from a gynecological hysterectomy? Look, here, a care of mother and fetus. The choice of anesthesia options are there because if you have opened it into spinal, from spinal you want to convert into GA, or if it is manageable in case of spinal, would definitely depend upon the vital status of patient at that time. Now, if it's a transfer cases, like if the patient is in anemia, of it has landed up with shock, hypotension, infection, the signs of dehydration, acid-base imbalance, electrolyte imbalance, all these DIC distorted anatomy, the initial from anemia to DIC are like an uncontrolled PPH in spite of all the efforts. So, and the patient deteriorating to a high level. So these are the initial steps. How does it differ from a gynecological hysterectomy? It's of course, everything in our profession is a team effort. Call for help always remain the first thing to be done. There is a blood bank, like a blood support has to be there. Invasive monitoring has to be there. Since there is increased vascularity, there would be, even if we are going for hysterectomy, the bleeding or hemorrhage would be more. The size of the uterus, definitely the size of the uterus is bigger, is difficult to identify the extent of the cervix. Next. Now, operative, it could be abdominal incision, it could be vertical or transverse. If we are doing a cesarean section, already a fenestral incision has been taken, and if it is feasible, we should proceed with the same incision. But if in case of normal delivery, uncontrolled PPH, and nothing has been there, in this case, we need to always open it through a vertical incision. Ma'am, can I have the previous slide, please? Previous slide, ma'am.
Previous one.
Previous one.
No, not
Previous.
behind. Before.
That is it. That's it, ma'am. Vagina may be sutured prior to the removal of clamps, and drain may, in this cases, we might have to leave the drain coming out of the vagina. We have to avoid suturing of the utero-ovarian stump to the vaginal angle. In this case, we have to take care of this thing. Next slide. Now, prevention of excessive blood loss in cases of obstetric hysterectomy. Uterine artery embolization remains one thing. Internal iliac ligation. Even if we are going for a hysterectomy, we have proceeded for it. Internal iliac ligation always remains a better and a safer option along with obstetrical hysterectomy. We have to remember. Temporary occlusion of ovarian arteries have to be done. Now, the last step and a very important invasive procedure that could be taken is of the uterine artery embolization. It is highly feasible, safe, beneficial procedure, possibly precluding further laparotomy or hysterectomy. If successful, not only saves the patient life, but also preserve the function of the uterus, tubes, and ovaries. But definitely, it has its own restriction in the way that uterine artery embolization would definitely, we would need an expert for doing it. Not all the centers at periphery level have this as their edge, so we should always be well equipped with all the surgical procedures for the management of PPH. Thank you.
It was a wonderful and excellent talk, I must say. Very nice.
Thank you. Thank you. Thank you, Monica ma'am, for helping me out at the last moment. I was having issues in sharing the slides, and you could help me out.
No, it was my pleasure. And so many conservative sutures, few of the sutures I have also heard for the first time.
Yes, never heard of them.
Never have you. We usually knew only 3 or 4 type of the sutures. Amen, B-Lynch, jaw sutures. But so many sutures I knew today only. I think Dr. Shivcharan was also going to join. He's having some difficulty in joining. He was a chairperson for this. Beena ma'am, are you there? You can give some expert comments. So I think Beena ma'am is not there.
Dr. Savita.
Yes, ma'am.
Dr. Savita, you want to say something?
Yeah, ma'am. So many sutures I'm also reading or seeing first time, and this is very expert and this is very useful, ma'am. Thank you for sharing your kind expert opinions and informations with us, no? Thanks for making me a part also. It's a very day-to-day practice, usual thing, ma'am. Thank you.
Thank you. Would anybody else like to give any inputs on this talk? Because I think it's been a wonderful session, both on the medical as well as the surgical management of a major cause of maternal mortality and morbidity. And if the
ma'am, can we go ahead with the next session?
We are running short of time. We should move to
the next session is by none other than Dr. MC Patel, sir, and he's going to speak about legal issues and obstetric hemorrhage. So can I introduce the chairpersons for the session? Dr. Ritu Gupta, madam. She is the president of the Bharatpur OBGYN Society. Dr. Anil Goyal, sir, secretary of Bharatpur OBGYN Society, and Dr. Sarika Gupta, madam, consultant at Kiran Nursing Home. Dr. Ritu Gupta, madam, is a director at Dr. Vinod Gupta Hospital Private Limited, and she's serving humanity since last 23 years. Currently, she is the president of the Bharatpur OBGYN Society.
Can you put the CVs?
Dr. Anil Goyal, sir, has more than 19 years of experience. He is the ex-joint secretary of IMA Bharatpur, secretary of the Bharatpur for OBGY Society, and he is the director and consultant at the Om Sat Hospital Private Limited. Our next chairperson is Dr. Sarika Gupta, madam. She is a consultant at Kiran Nursing Home, and she is from SMS Medical College. We welcome our chairpersons to please introduce our speaker, Dr. MC Patel, sir.
Dr. Sarika, please introduce MC Patel, sir.
Is anyone there?
Hey, Sarika, Dr. Sarika was there.
Sarika, ma'am? Ma'am, please unmute yourself. We can't hear you. No, still, you have to unmute yourself, ma'am. The tech team, please give her a prompt to unmute.
Please,
Yes,
now
ma'am.
unmute. Ha.
Good evening, everyone. Myself, Dr. Sarika Gupta. Am I audible?
Yes, you are very much audible.
It's my privilege to introduce Dr. MC Patel, sir. He's a very learned person, and he's standing for the candidature for Foxy President Election 2026. Foxy, can I have the slide of introduction of Dr. MC Patel?
Yes, it has been showing on the.
It is already on the display.
It is
Okay,
already on
okay.
the display.
Okay, thank you, ma'am. He's a medical legal. His key highlights are medical legal training and support for members. He's vice president Foxy in 2018. He's chairperson of Ethics and Medical Legal Committee from 2011 to 2013. He's organizing secretary of AICOG in 2017. He's honorary secretary and state organization of Gynecologists and Obstetrician of Gujarat, SOGOG, from 2022 to 2025. He's organizing first chairperson, Vice President Congress 2018, Honorable Member Foxy, PNDT, Violence Against Doctors and Regularly Cell. His government and statutory roles are PNDT, NIMC, Government of India 2015, Gujarat PNDT State Supervisory Board 2005 to 2009, National Managing Body, Indian Red Cross Society from 2019 to 2022. He has a list of community and services. He's honorary surgeon, Red Cross Society, iBank, collected 1,000 eye pairs, services in medical camps in Northeast states under Dhanvantri Seva Yatra under NMO and Seva Bharati organized since 23 years. Services in medical camps in Jammu and Kashmir under Dhanvantri Seva Yatra under NMO and Seva Bharati organized since 6 years. President of Lions Club Khadlodia from 1997 to 98. His professional leadership includes President AOGS 2010 to 2011, President IMA Ahmedabad 2007 to 2008, National President NMO 2016 to 2018, Organizing Chairperson Vivekanand NMO Congress 2013. It's my privilege to introduce Dr. MC Patel. Over to Dr. MC Patel.
Yes, thank you, madam, for kind words. Let me share my screen. Is it seen?
Yes, sir.
Okay. And is it seen full screen?
Yes, sir.
Okay. Greetings from Statue of Unity, tallest statue of world, and we all are proud of that statue. Warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank all the joining societies who have joined this webinar and President and Secretary of respective societies who have joined this webinar. And before I go to the subject, it is my humble request, humble appeal, please endorse my candidature for post of President Foxy election year 2026. And at the same time, my commitment will be there. Wherever you are, I'll be there. Promise to reach the unreached. Usually I start any of my talk with this question. Is it worth discussing? Yes. And if it is yes, then why? Because medical litigations are increasing in number. constantly and steadily, and unluckily we gynecologists rank first. Any area you go as far as litigation is concerned, whether it is civil suit, criminal cases, police station cases, uh, Human Rights Commission, National Commission, then Medical Council. But we gynecologists are in driving seat as far as number of litigations are concerned. And we take utmost care of any of our patient in any given situation, just like obstetric hemorrhage. But we never know, accident may happen. And once accident happens, then it becomes difficult for us to face the situation. And this is our obstetric practice. We have to save mother, we have to save baby, and at the same time, we have to save our own cap. Let us say it is a real happen case decided in National Commission. It was case of cesarean section, atonic PPH after cesarean section delivery, uterotonics given. In spite of applying the suture, bleeding PV was 3+, informed consent was taken, and subtotal hysterectomy was performed. Blood and its components transfused to correct hypovolemic shock. Case was filed, and argument was that it was life-saving emergency and pursued standard medical textbook, that is So's textbook and Williams textbook. And from those textbook, all the references were given that what is atonic PPH and how it occurs and what could be the line of management once atonic PPH occurs. So in this particular case, inference held by the court due to this references of standard textbooks of Williams and Shaw and other cases, the postmortem examination, postpartum hemorrhage is a well-known complication. It is dreaded and leading cause of maternal morbidity and mortality worldwide, even in the base center. The process of childbirth can take a lethal turn. Only a qualified obstetrician can understand uterine atony after childbirth as the most common cause. It can lead to rapid and severe hemorrhage, shock, DIC, multiple organ failure, and finally death. In few studies, the most common indication for emergency obstetric hysterectomy was uterine atony. Almost in 25% of the cases, uterine atony led to obstetric hysterectomy, followed by morbidly adherent placenta, that is 21%, and uterine rupture, that is 70%. So uterine atony was the main cause for obstetric hysterectomy. It was studied and inference held by the court. This reflects that situation in most developing country where atony accounts for majority of cases of emergency obstetric hysterectomy, but also shows rising. So furthermore, inference held by the court was, if all attempts at arresting bleeding have failed, subtotal or total hysterectomy is attempted as a last resort and life-saving measures. The decision to perform hysterectomy, although devastating for patient, should not be delayed in cases of hemodynamically instability. So in this particular case was dismissed in favor of doctor because doctor had taken utmost care of that very patient in that given situation. So in this type of situation, ultimate result is not taken into consideration, but your efforts to save life of patients are taken into consideration. So which are the areas for litigation? Which are the most common allegation in this type of situation? Delayed in diagnosis, investigation or treatment, misdiagnosis, investigation or treatment, wrong diagnosis, unnecessary investigations, no proper consent, staff not qualified, infrastructure issues, emergency services not rendered properly, communication failure, delayed in transfer, complications, morbidity, maternal and or fetal, mortality, maternal and or fetal, overcharging. Sorry, what happened? tremendous expense against unexpected result is nowadays very common allegation in a litigation part. Ask for medical record, and if you have not provided, then also it becomes a one part for litigation. And failure of patient to keep up scheduled follow-up. If you have advised patient to come for follow-up and patient didn't turn up and she may end up into any complication, then also it becomes a case. But in this case, it becomes a good defense in our favor if we can prove that we had advised patient certain treatment or follow-up and patient didn't comply, then it becomes contributory negligence on part of patient and it is a good defense in our favor. So which are the areas in this type of particular when we are facing case of, say, for example, obstetric hemorrhage, then very common allegation would be not anticipated and not prepared to manage that very situation. And very important question, was it preventable? Say, for example, if it is a case of obstetric hemorrhage or PPS, we can say that was it preventable? And usually you cannot say no. So if it is yes, then what did you do to prevent it? So which measures you took to prevent PPH is also taken into consideration. So proper management of third stage of labor is taken into consideration. We have to prove it by our record. And if you couldn't prevent it, and in spite of all your efforts, PPH occurred, then one more question, why you couldn't prevent it? So you have to reply that also. And very important part, did you diagnose in time, whether it was PPH or any other obstetric hemorrhage, but did you diagnose well in time? And very important question, did you manage way in which any prudent doctor would have managed? So if you can manage case way in which any prudent doctor would have managed in that very given situation, then you could be out of problem. One more area, delayed in diagnosis. Again, you will have to face all this set of question. Recurrence, we know in PPH once or in APH, or rather say, for example, if it is a case of placenta previa and one bouts of antenatal hemorrhage occurs, we know that recurrence is known, but many a time if we cannot explain patient well, then this could be a common allegation. No proper care taken to avoid recurrence. So we have to counsel patient in such situation that recurrence is known in this type of situation and you are supposed to report hospital immediately if at all you have one more bout of APH. So in this situation, we should be very clear. As far as PPH is concerned, if first part is well controlled, secondary PPH may occur. So we have to explain about that also. Again, we will have to face all those questions just we discussed. So it is our observation that 80% medical legal cases against gynecologists are obstetric related cases. And out of those, 80% of the cases are related to cesarean section complication. And out of those, 80% complications are related to hemorrhage. So it simply means if you want to be out of problem in 80% of the cases, then take care of bleeding and cross-match blood and transfuse blood well in time and manage postpartum hemorrhage or any obstetric hemorrhage well in time. Let us see one more case. It was case of cesarean section, and during that cesarean section there was bilateral uterine artery tear. Patient was Rh negative, blood was not ready, cross match was not done. During shifting patient to Municipal Medical College Hospital, patient expired on the way. Notice was served, case was filed. Allegation was not anticipated complication, procedure, or intensive care. And in this particular case, inference held by the court was postmortem examination report was like this: intra-abdominal hemorrhage following negligent surgical procedure, no blood kept ready, medical record not to be believed. Because in this particular case, in note of obstetrician, she had mentioned that vitals were within normal limit. And at the same time, in note of anesthesiologist, it was written that vitals were compromised. So note of gynecologist and note of anesthesiologist were in contradiction. So court didn't taken into consideration about medical records submitted, and in this particular case, compensation of rupees 2.35 lakhs was awarded in favor of relative of patient. So with this type of cases, carry home message is very clear, and a very common reason for litigation is not cross-matching blood during high-risk pregnancy cases like Rh negative. So what is carry home message in this type of situation? Would you advocate prior cross-matching in each and every patient at the time of admission only? Because many of our friends have a habit. On admission, they send blood sample in nearby blood bank and keep 2 units of PCV or any other blood ready. So if at all in emergency it is required, no precious time is wasted. And if it is not required, then they can ask blood to release that blood to anybody else. So, of course, it is not legally compulsory, but if you have taken like this, then it shows your concern to save life of patient. So, particularly when you are dealing with a patient of Rh negative, naturally you have to send cross matching in nearby blood bank, because we know in case of Rh negative, it becomes difficult many a times to manage for blood or blood product. Consent for blood transfusion. If blood transfusion is very much arranged well in advance, then prior consent is very much must. Otherwise, at the time of blood transfusion, we have to go for separate consent. And proper record keeping is very much must in this type of situation, because we know obstetric hemorrhage are just like 9/11, and it is very late sometime when we diagnose the thing, and one cannot be smarter like this every time. And after the ship is sunk, everybody knows how it could have been saved. So once case has happened, everybody retrospectively can discuss that it was better if we would have done this, we would have done that, but it is late in these cases. So every cases of obstetric hemorrhage is potential threat as far as litigation part is concerned, and treating serious patient could be suicide as far as medical legal problems are concerned. And we are bombarded with so many questions when we are facing any cases of obstetric hemorrhage. Why this happened? Where were you? Who is responsible for that? Why you couldn't prevent it? So how it occurred? So we are bombarded with so many questions. So what to do and how to prevent all this? We have to observe only 3 things: foreseeability, that is anticipation; good communication, that is proper consent; and proper documentation, and you could be out of problem. As far as foreseeability or anticipation is concerned, we are expected by law and court that we should anticipate certain complications, and we should be readily available with procedure or intensive care to deal with the situation. Say, for example, if you are dealing with a case of central placenta previa, naturally one should anticipate that she may end up into PPH, she may require blood transfusion, she may require obstetric hysterectomy also. So we should be ready to deal with this type of situation. And when one should be vigilant or anticipate PPH, it is also expect from court. And if we are facing this type of situation, we should be alert and we should be readily available to deal with the situation. So as far as atonic PPH is concerned, it is likely in this type of situation: multiple pregnancy, grand multiparity, large baby, anemia, polyhydramnios, prolonged labor, placenta previa, placental abruption, retained placenta, remnant of placental tissue, retained amniotic membrane, blood clots, mismatch, 3rd stage of labor, and full bladder. So in all these conditions, we should be alert and we have to manage patient accordingly, because if at all you are facing PPH after any of this condition, court will naturally ask that what did you do to prevent PPH when you are knowing that it is likely that she may end up into PPH. One more area. Would you like to involve other colleague if you are facing a case of any obstetric hemorrhage, particularly PPH? Would you like to treat alone, or would you like to involve your professional colleague? So no IM only consultant approach. Involve professional colleague always in this type of cases, and preferably since beginning, because it shows your concern that it has taken utmost care to save life of patient, because balanced teamwork is always beneficial, not to the patient only, but to you also. But in all this condition, proper counseling is very much must. So would you like to give guarantee in this type of situation when you are dealing with any case of obstetric hemorrhage? No rosy picture about result, no tall claim about result, because in eye of law, when you claim to be master, you are supposed to be master. And in our obstetric practice, when we are dealing with any obstetric hemorrhage, we consider result like Aishwarya Rai, but it may turn like this at any time. So no rosy picture, no tall claim in obstetric hemorrhage. And records are always at our rescue. So we have to keep them up to date. What was done, nothing was neglected, given treatment fully met the standard demanded by law and ethics, and it should be easily acceptable whenever offered in the court. So we should be well up to date as far as our record keeping is concerned, which measures we have taken to prevent PPH and to manage PPH or any obstetric hemorrhage. We have to prove it by our meticulous record. As far as important bills are concerned, say for example, purchase of oxygen cylinder, defibrillator, ventilator, emergency instrument like ambu bag, and all emergency drugs. And not only purchase of oxygen cylinder, but refilling of oxygen cylinder bill is also part of your record, and it is a very important document in your favor. Because in this particular case, allegation on part of relative of patient was when patient suffered heart attack, oxygen cylinder were empty in the hospital. And we were saved in this particular case only due to we could produce bill of repurchase or refilling of oxygen cylinder just 1 day prior. So refilling of oxygen cylinder bill is also very good defense and very good document in your favor. Transfer of patient. Many a time we have to transfer patient to higher center. So in this situation, it should be in time at proper hospital. And when you are referring patient to any other hospital, confirm availability of bed, ventilator, OT, blood, because many a time when patient reaches that very hospital and ventilatory support is required and ventilator is not available. So patient will have to be shifted to another hospital and precious time is wasted. So whenever you are referring patient to any other hospital, confirm availability about all this with right and proper person. Escort patient in the same ambulance. It is very much must with all emergency drugs, IV line on, oxygen on, and if blood is arranged, then with blood also you can transfer patient to higher center. Handing over patient to right and proper person is very much must, and you will see that treatment at that very hospital is started in your presence, because many a time precious time is wasted in starting of the treatment even after patient has reached well in time. And transfer document, we have to give all the transfer document to the patient, and use of pneumatic anti-shock garment is also very much must in case of shock. It shows your concern that you have taken utmost care of your patient. As far as transfer documents are concerned, we have to give all this detail, but we do not want to go into detail. This is checklist, which kind of document you have to give given to the patient, and it is available on Foxy website. Preserve transfer document, whichever you have given to the patient party. So on Foxy website, you have to simply visit Foxy Uniform Consent. There are 30 different consent available on Foxy website with 3 medical legal experts, Dr. Dilip Walke from Pune, Dr. Nikhil Datar from Mumbai, and myself, Dr. MC Patel from Ahmedabad. We have prepared 30 different consent, and in those consent, how to transfer patient to higher center, which kind of document we have to give to the patient is given in that very consent form. You have to simply download and you can use in your day-to-day practice. So there is always a way to deal with the situation. So to conclude with Carey Holmes, antenatal and labor ward protocols we have to strictly follow. If you have managed patient as per standard medical norms, standard medical protocols, then it will be easier for us to face in court of law. Adequate supervision and monitoring during antenatal period, during labor and after labor, and during surgery, after surgery also. Communication, counseling and proper consent is very much must. Proper documentation and proper record keeping, foreseeability and anticipation, in-time transfer, multi-speciality approach, medical audit of our own case where things went wrong, not to end up into same problem in future. So medical audit of our own case is also very much important. Indemnity in era of CPA, you cannot afford to practice obstetric without coverage of proper indemnity cover. So realization, medicine is a science of uncertainty and art of probability. And problem with world is that intelligent people are full of doubts while stupid ones are full of confidence. So we have to decide where we stand and remain alert every time. Otherwise, be ready to face this type of situation. This gentleman has so many staircases, but he doesn't know how to use them. So it doesn't matter how many resources you have. If you do not know how to use them, they will never be enough. So have some basic legal knowledge and always obtain medical legal advice whenever you are in doubt. So if you want to sleep like this, take tender care of your patient, pray Almighty God before going to sleep, and keep my visiting card below your pillow, because I am always there to assist you in any odd given situation. So all the best. God bless you. Have a litigation-free medical practice. With regards, and before I end, please endorse my candidature for post of President Foxy election year 2026. And at the same time, I would like to thank you all the Society of Rajasthan. They have nominated my candidature for post of President Foxy, and I am very much overwhelmed with response of all the Society of Rajasthan. They have nominated me, and I am quite sure they are going to vote for me also. Salute to all. Thank you. Thank you very much. Please do not assume. Please ask if any query, any question, if time and chairpersons permit. Thank you. Thank you very much.
Thank you, sir. It was a wonderful talk. Though we have listened to your talks before also, and every time we see, we are just simply amazed by your inputs and new things which we are, you always try to communicate about the legal issues and where we are likely to get stuck. So thank you so much,
Thank
sir.
you.
And
Thank you.
all our support from Rajasthan will be there for you.
Thank you, madam. Thank you.
So, Monica?
Yes, ma'am. Should we move ahead with the program then?
Yes.
Yeah, after those 3 wonderful talks, we have a very important panel discussion coming up. It's on saving mothers' lives, innovations, and best practices in PPH care. We have Dr. Taruchaya Bansal ma'am and Dr. Neelam Jain ma'am as our moderators. Dr. Taruchaya Bansal ma'am is the secretary of NARCHI, or the state branch of Rajasthan. Ma'am is based at Jaipur. She is a consultant and director at Bansal Hospital at Shamnagar, Jaipur, and has been the past secretary of Jaipur Obs-Gynae Society. We welcome you, ma'am. Our next moderator is Dr. Neelam Jain ma'am. Dr. Neelam Jain ma'am is the president of NARCHI, Rajasthan. Ma'am is presently the National Quiz Committee chairperson, president of the National Association of Reproductive and Child Health Care, Rajasthan, and a senior consultant at SRK Hospital, Lalkoti, Jaipur. Welcome, ma'am.
Yeah.
We have Dr. Subha Sethia ma'am and Dr. Madhulika Agarwal ma'am as our experts for the panel. Dr. Subha Sethia ma'am is the past president of Jaipur Menopause Society and has been the vice president of Jaipur Obs-Gynae Society, as well as the secretary of Jaipur JMS. Welcome, ma'am. Our next expert for the session is Dr. Madhulika Agarwal ma'am. Madhulika ma'am is a senior consultant at Agarwal Hospital, Jaipur, secretary of the Jaipur Menopause Society, and has been the vice president of Jaipur Obs-Gynae Society in 2022 to 2023. Welcome, ma'am. We have 8 panelists with us. Our first panelist is Dr. Richa Gupta. Dr. Richa is consultant gynecologist and laparoscopic specialist from Bharatpur. Welcome, ma'am. Next, we have with us Dr. Nidhi Gupta, ma'am. Dr. Nidhi Gupta, ma'am, is a consultant gynecologist at Jaipur, senior consultant. Then we have with us Dr. Ashok Naniwal, sir. Sir is the president of the Pali Obs-Gynae Society. Welcome, sir. Then we have with us Dr. Renu Setia, ma'am. Dr. Renu, ma'am, is the president of the Hanumangarh Obs-Gynae Society. Welcome, ma'am. We have with us Dr. B.L. Rar, sir. Sir is the professor and HOD of GMC Shikar. Welcome, sir. Then we have with us Dr. Manju Singh, ma'am. Dr. Manju Singh, ma'am, is the past secretary of the Bharatpur Obs-Gynae Society. Welcome, ma'am. We have with us Dr. Sharmila Atolia, ma'am. Dr. Sharmila Atolia, ma'am, is one of the senior gynecologists with us. Welcome, ma'am. Last but not the least, we have Dr. Indira Lamba, ma'am. Dr. Indira, ma'am, is a past secretary of the Jaipur Obs-Gynae Society. So over to you, moderators. Looking forward to an excellent panel discussion.
Thank you so much, Dr. Shatabdi. Everybody can see the screen. It's easy.
Yes, ma'am.
Yeah.
Yes,
So
ma'am.
today the panel discussion is on postpartum hemorrhage. Till now we have so many things to learn about postpartum hemorrhage. The most common reason for maternal morbidity and mortality accounts for substantial number of deaths across the world, although it is preventable too. We all know it. So early diagnosis, action in golden hour, timely refer, they are the key for the management. So this panel is case based and very easy. Everybody knows everything. We were just discussing it. So case 1 is a 35 years old, gravida 6, para 4, live birth 4. Woman was admitted in active labor at 38 weeks, 3 days, period of gestation, and had a spontaneous vaginal delivery. Within 15 minutes, she developed heavy vaginal bleeding. Pulse rate was 104, blood pressure 100/70, and uterus was found to be flabby and she was bleeding. Dr. Richa, what is your diagnosis and how would you define it?
This is a case of primary atonic postpartum hemorrhage. It is defined as objectively measured blood loss of more than 300 ml with any abnormal hemodynamic signs. Since pulse is more than 100, shock index is more than 1, systolic blood pressure is less than 100 mmHg, and diastolic is less than 60. Thank you.
Very nicely said. With the FIGO guidelines, we say that objective measured blood loss is more than 500 ml. But if it is less than 500 ml, more than 300 ml, but with problems, that signs like pulse is rising and shock index is more, then we consider in both ways it is PPH. Dr. Neelam?
Yes. So what are the risk factors for atonic PPH? I think we have already covered this, but Dr. Nidhi, can you just summarize? Dr. Nidhi, are you there? Next slide. I think if she's not there, we can just summarize. We have already, even Dr. MC Patel had just covered that it is anemia, multiparity, overdistension of uterus, polyhydramnios, multiple pregnancy, macrosomia. Then it could be infections like fever, prolonged rupture of membranes, any fibroids, and placental causes like placenta previa, uterine anomalies there, prolonged labor, precipitate labor, and uterine relaxants like nifedipine and magnesium. Next.
What is the significance of golden hour in PPH? Dr. Ashok Naniwal? Dr. Ashok? The golden hour is the first 60 minutes from the time of recognition of PPH in which resuscitation must begin to achieve maximum survival. As more time lapses, Between the time of severe shock and start of resuscitation, the percentage of surviving moment decreases. So it is very important to understand first 60 minutes. Anybody else can also answer. And Dr. Indira?
Yeah. Yes, as you told, the first R is the golden hour because uterus can bleed up to 800 ml per minute. So we can lose the female within 10 minutes only. And these first hour, we have to resuscitate the patient by replenishing all the blood loss and by handling with the attorney.
Once the patient goes in irreversible shock, it is difficult to treat. So always remember to treat as soon as possible without delaying. And don't think only, act promptly. This is the message I want to give. That act promptly. And in this case also you could have anticipated because the patient is a multigravida. So you could have anticipated and be prepared for PPH.
Rightly said, Dr. Madhulika. So how does the shock index assist in the early detection of severity in PPH? Dr. Renu Setia. Dr. Renu? Dr. Renu, are you there? Next slide. So, Dr. Indra, if you want to take
Yes, why
shock
not?
index.
Actually, shock index is a heart rate upon systolic blood pressure. And mostly in a normal patient, it is between 0.7 to 0.9. But if it is more than 9, that means you must be alert that something is happening with the patient. And shock index, if it is more than 1, then you have to start blood transfusion to resuscitate the patient to replenish the blood losses. These days, we are also come with a new term, modified shock index, which is heart rate divided by mean arterial pressure. Normally, it is between 0.5 to 0.7 in a healthy patient, but if it is more than that, then we have to start our resuscitative measures and all the measures to control the blood loss.
Yes.
One thing I want to say, that don't rely on blood pressure only, because of the physiological changes in the pregnancy, the woman blood pressure falls only after 30% of the blood loss. So the shock index is more reliable and it is very easy to calculate.
Yes.
You can just take the heart rate and blood pressure and calculate and manage accordingly.
Yes. So the message is that if it is more than 1, you have to go in for the resuscitation protocol and the blood transfusion protocols. Next.
What are the general measures to be taken in management of PPH? Dr. Ram, if it is there, I don't think he is there. Dr. Richa Gupta, do you want?
Yeah, I can answer it. General measures like we can call for help, evaluate vitals and shock index, catheterize the patient. We should estimate the blood loss, rapidly assess uterine tone, systematic genital tract examination for traumatic PPH. Then we should have 2 peripheral venous lines, more than 14 gauge. Send blood for like blood grouping, cross matching, CBC, hematocrit, PT-INR, APTT, and oxygen mask should be started. And keep the patient warm, arrange the blood and blood products.
Very nicely said. Dr. Neela?
Yes, from visual estimation to objective tools, how can blood loss be quantified during postpartum hemorrhage? Dr. Manju Singh, if you are there. Otherwise, anybody can take. Dr. Sharmila, if you want to take this question.
Ma'am, we can estimate it by the method based on gravity and volumetry measurement. And
Very
other
right.
is visual methods and visual estimation and collaborative cards.
Yeah.
But
Dr. Taru, next slide.
Do you think, Dr. Sharmila, visual method is better?
ma'am, visual method is we can do easily at the site, but the collaborative method are well. much
Yes,
better.
volumetric measurement, especially the blood suction collectors in cesarean and blood collection bags for vaginal birth, which have calibrations for 300, 600 or 900, and we can very easily measure them. Anything about hemoglobin measurement before and after cesarean that can also be done?
Like decrease in the before the school of
Actually,
30, 30
Yes,
hemoglobin
drop
level is
is
not
and
very much
30%.
feasible because it is a dire emergency and we can get we have to spend some time to get the results. So if there is an expert person, then visual measurement is the utmost. Otherwise, we can use calibrated drapes in routine in every patient. In every patient, we can use the calibrated drapes. There is a bag where the blood gets collected, and we can very well make out whether she has lost, what amount she has lost, and we can then, and in also in cesarean we have calibrated collecting this flask where we can very well make out the blood loss. So
Yes.
most appropriate and most practical is the calibrated.
Yes, very well said. Actually, just after delivery, we should always put calibrated drip under the patient in normal delivery, so that we can come to know what amount of bleeding is there. Otherwise, visual calibration, at times we can miss the amount of blood loss.
Dr. Indra, I just want to ask, is it available at Mahila Chikitsalaya?
Yes, it is
Calibrated
available. It is
Or do you-
available here in Mahila Chikitsalaya. We are using routinely in every patient.
Yes,
There
and
are disposable. There are
yes.
disposable calibrated drapes which are kept under the patient, and when there is excessive bleeding, we can very well make out by looking at it. Moreover, there is a display of vitals, blood, heart rate, and then pulse rate, and BP. The pulse rate starts increasing first, and then we see a reflection on the
Blood pressure falls later.
blood pressure. So that's why the shock index is very valuable in such cases, because there is the heart rate is the first thing which will reflect that something wrong is happening with the patient.
Very right.
Yes.
And
These are few visual
as
estimation of blood loss.
these are some of the sanitary towels, and we have been using them day in and day out. And we know that it is 30 ml or 60 ml or whether 25, 50, 75, according to the saturation of the blood.
Sponge.
These are the
Sit
quick
down, Kalvi.
assessment tools.
Yes.
At periphery, sometimes the
How
drape
should we
is not available. So we can teach our staff how to measure the blood on just by seeing it. At least they
Yes.
can guess it. If something wrong is going to happen, and just
Yes,
inform
if
the
it is on the
doctor or
floor
ship the
of,
patient.
or if it is on
Yeah.
the spill is on the bed, or the
If blood
kidney
clot
tray
is
is
more
full.
than a fist size, that means the
Yes.
100 ml of blood is
It is
lost already.
more than 500 ml has already been lost. So, how should PPH be managed from the point of first recognition to definitive control using a systematic bundle and motive framework? Dr. Taru?
Dr. Indra?
Yes, actually, PPH is a very dire emergency in our OBS cases. It is the fastest of all the killers. And as I have already told that uterus can bleed up to 800 to 1000 cc per minute, and the patient may collapse within 10 minutes. So we have to be very much alert about this catastrophic event. And for this dealing, PPH bundle has been given by our Foxy. This bundle consists of readiness. Utmost important thing is readiness to deal with this catastrophic event. Readiness means we should have a team assigned for dealing such an emergency. The team should have team members who should be allocated beforehand what they have to do if such a patient comes to our institute, or patient lands up into PPH. The readiness and the rapid response is very important. And before that, recognition and preventive aspect is also important. As I have already told, we are using these drapes where we can very well make out how much bleeding has occurred and whether the patient is landing up into the PPH or not. After recognizing the problem, then we should be very rapid in response. The response is at most important. Early detection and response can save many of the patients. In response, we should go for all the things. We should shout for help. We should start IV infusions. We should catheterize the patient, put 2 IV bore needles before these veins collapse and the patient and the IV access becomes impossible. And after doing all that, we can shift to next. We should also send the blood for cross-match if it has not been done beforehand. And then meanwhile, when the blood comes, we can start IV crystalloids, IV fluids, and at least 2 liters of IV fluids have to be given. And such patient with rapid depletion of blood volume, they'll end up into DIC. So we have to send for the blood for PT-INR, APPT, for fibrinogen level, which is very important. Fibrinogen level should be more than 150, and because we need this adequate amount of fibrinogen for clotting of the blood. So we have to follow the emotive means early detection and trigger criteria, as we have already talked about. Around 300 to 500 milliliter of blood loss within first hour of birth denotes that the patient is going into PPH, and we have to monitor for the blood flow. Then every 15 minutes we have to see for heart rate, BP, and after that we have to start uterine massage in so that the uterus becomes contracted and the bleeding stops. We have also started oxytocin drugs. Oxytocin, mainly we are using oxytocin 10 units IV as a bolus of slow IV, and then we can start maintenance dose of 20 international units and 1 liter of saline. We should be finished within 4 hours. Tranexamic acid has also been added to this bundle approach because it is very helpful to control bleeding. It is never preventive, but it is curative. 1 gram of IV bolus should be given, diluted, or we can use it diluted 200 ml of crystalloids, which has to be given within 10 minutes. Moreover, IV fluids, as I already told, we have to start with crystalloids. And if the blood is not available, then we can also start with colloids. And if the blood is available, then we have to use packed RBCs, 1:1:1 ratio, packed RBCs, FFP, and platelets. And still, if the patient is bleeding, then we have to re-examine the patient. We have to empty the bladder, see for any injury, see for any missing cotyledon of the placenta, see for whether there is any retained product of conception and membrane. We have to remove them. And then we have to, still the patient bleeds, then we have to escalate and to jump to the next type of management, where we can go for tamponading, for suturing, for other help.
Very nicely described, Dr. Indra. You have summarized all about emotive. I think you have already told about uterotonic drugs that are recommended as the first line agents in PPH management, that is oxytocin. And you have told about the bolus and everything that should be done. That is 10 units of IV oxytocin. It can be injected slowly or it can be infused, and then it can be continued for a period of 4 hours if 20 units are given and diluted in 1000 ml. And the next is ergometrine. If the patient doesn't respond to oxytocin, then IV ergometrine. Can anybody else describe about ergometrine and the
Yes,
rest of
I
the
want to
drugs?
say something.
Yes.
It has to be.
I don't know how many of you agree with me, but ergometrin is a wonder drug. I experienced one patient in whom I tried everything. Then मैंने sister से कहा कि अब इसको methergine लगा दो, and the patient responded so well. So if there is no contraindication, I think there's no harm in giving ergometrin.
Actually, the contraindication is hypertension, but since the patient is already hypovolemic, so we can very well use ergometrin. And earlier we used to use it in routine. It was a routine. Yes, it was used for prevention also, not only for treatment. It was being used for prevention, but people were using it inadvertently without seeing any side effects. That why it has been withdrawn.
That is helpful.
Yes, otherwise there
And-
were only two drugs when we
Yes.
started our post-graduation.
Yes.
Only oxytocin and ergometrin were there. And
Yeah.
the rest of the
Moreover,
drugs
prostaglandin was also used in routine, but
later
the
on.
contraindication is asthma. In
Asthma.
such a situation, we are not able to take the history of asthma and all, and it is very dangerous to use the drug in asthmatic patients. So it has also been withdrawn. Otherwise, it was in routine use. We used
Very
to
rightly said.
give
But symptometrin
intramuscular.
भी use किया है हमने अपने
Symptometrin.
at that time
It
it
is
was
also wonder
available.
drug. Actually, where the cold chain can't be maintained, there we can also go for such type of drugs.
Yes.
और prostaglandin को कोई IV ना लगा दे, ये भी important है.
Yes. So come next, we can go for the next pharma role of tranexamic acid that Dr. Indra has already told that it should be used within 3 hours. Otherwise, it will not have any effect on the patient. And the earlier it is used, the fast it is used after recognition of PPH, and it has 70% improvement in survival of the patient. It has been seen, and as the time elapses, the its role decreases. So
Actually,
early
in our medical college, we are now using it in a routine manner, not only in PPH. If some sort of bleeding is there, छोटे जो bleeders oozes, then
तो
also we
routine
are
में आप
using
दे
it.
रहे हो.
Yes, we
Yes,
are
it
giving it
has a
routinely.
wonderful drug. And in episiotomy also, sometimes it bleeds so much. And once you
Yes.
give one shot of tranexamic acid,
It
all bleeding
helps.
stops.
It really helps.
Helps.
And there is no contraindication to it.
Except it causes hypovolemia, hypotension.
Yeah, it causes
Some patients.
hypovolemia, no
But
doubt.
you
But
always give in drip along with drip.
So next question.
How is carbitocin administered in PPH management, and what is the therapeutic role? Dr. Nidhi? Dr. Nidhi, are you there? Dr. Sharmila Atolia, you can take this question if you want. Dr. Richa?
Actually, I also have a experience of using carbitocin. It is a long-acting synthetic analog of oxytocin only. So where the cold chain can't be maintained, this is a wonder drug. And it is given in a dose of 100 micrograms intramuscular and intravenous. And here it also works very well.
Slowly
Yes,
in
it is
1
heat
minute.
stable and is stable at room temperature. So that is
Yes.
the most
Should
important
not be given
advantage.
fast, it should be given
So,
slowly in 1
in
minute.
resource poor settings like subcenters, PHCs, and where the cold chain maintenance is not done properly. In fact, in our big institutes also, most of the nursing staff, they don't know that they have to keep this oxytocin at
In the
a
fridge.
certain
Yeah.
temperature.
So many
They
drugs.
keep either they keep it in freezer or they keep it in outside. So at such places, carbitocin can be a good alternative for
But
oxytocin.
once patient starts bleeding, then there is no role of carbitocin.
Yes.
It is preventive.
Yes, it is preventive, not curative.
इसको repeat कर सकते हैं कि carbitocin को can be repeated if the bleeding does not control.
How should a clinician proceed when PPH is unresponsive to first line uterotonic therapy? That is called refractory PPH. I think only Indra is left in panelist.
So should I answer it?
Yeah, please
I
inform
think,
me
yes,
that
As I
don't
have
sponsor us.
already told in emotive protocol, we have to escalate the response if the uterotonics and all the major, basic things are not working. Here we can perform bimanual compression of the uterus. For that, we keep one hand, left hand inside the or right hand, whatever is comfortable in the posterior fornix of the vagina, and the other hand on the abdomen, and then we try to fold the uterus in between so that the anterior and posterior wall of the uterus is compressed. But we can't waste time on doing the compression only. We have to perform it for 1 or 2 minutes, then we have to proceed further.
yes. So we are
Another
talking
thing,
about the mechanical methods. So one is bimanual, then aortic
yeah, then is
compression.
aortic compression. Aortic compression, we have to stand on the right side and then compress the left side of the patient with the left hand fist, so that and the pressure can be measured by femoral
These
pulsation.
are
If
only
it's,
temporary measures.
yes, these are only
Mechanical,
temporary
yes.
measures. And but uterine tamponade, I have a good experience with it. The Bakri balloons
Bakri
is
balloons.
very good, very good. It have saved lot many of uteruses.
And even in the PPH kit, you have to keep always a tamponade, whether it is
Yes,
a Bakri balloon or
yes.
anything else,
Or
because
we
it
should
saves
know.
life while
Yes, and we should
transplantation.
know how to prepare this.
If
I
it is
mean,
not
Condom
available.
balloon catheter. If it is not
condom
available.
condom
Yeah, because
catheter.
yeah.
We have to teach our under staff and all to prepare the condom balloon.
Yeah.
If Bakri balloon is not available, then we can very well control the bleeding with the condom balloon also.
Yes. And very right. And after this, still if it is not there, then we can use a PPH suction cannula. And NASG, we know that it is an anti-shock garment. So after that, we can go for a PPH suction cannula, and Panikkad suction cannula
I
is
have
there.
a experience of using it. I have this cannula, and in one patient I tried, and I saved the patient. And I put the cannula and with suction and created the suction to the highest and kept it for 15 minutes there. And after that, gradually release the suction, and the patient has
The
no bleeding.
WHO update says that plain gauze or gauze packing impregnated with hemostatic agent doesn't work, but in my personal experience, I have saved many uteruses by this method also.
Yes, I have
Actually,
also seen
whatever
this.
possible method हमको मिल जाए, उसको use करना है.
Yes,
We
if
should
we
not
pack the
बचाना है.
uterus very tightly with this gauze packing with hemostatic, it works.
अपना
See,
aim क्या है? Patient को बचाना है. जो available है
before
उसको
all
use
these
करो.
things came, before these sutures came and the cannulas came, we did uterine packing.
Yes.
Yes.
हम तुमने भी किए होंगे खूब.
किए हुए हैं, यूट्राइन पैकिंग करते थे
हमने
पहले.
हमेशा से करे हैं ये.
हमने
जो
किए हैं
available
और
है
हमने
उसको
अच्छे
करो.
रिजल्ट पाए हैं इसके.
नहीं, और कई बार होता है कि पेशेंट का इतना एटोनिक है कि डिस्पाइट पैकिंग साइड से ट्रिकल करना शुरू हो जाता है, तो फिर भैया एस्केलेट करो फॉरन उस टेक्निक पर. तो पेशेंट रिस्पॉन्ड नहीं
मेन थिंग
करेगी.
इज कि हमें किसी एक पॉइंट पे रुके नहीं रहना है. वी हैव टू ट्राई वन और अदर जल्दी जल्दी आगे आगे स्विच करना है. वी हैव टू जज.
विजिलेंट. Yes.
We have to vigilant. We have to judge the condition, whether the patient is deteriorating or improving. If the patient starts improving, then we can halt the process. Otherwise, we may go for hysterectomy also.
Yes.
The thing is, we have to be vigilant and don't waste time on any one method.
Yes.
There is no use of saving uterus and losing the mother. So our aim is to save the mother.
I think all the surgical methods have been beautifully described and discussed. So, Dr. Taru, can we go for the next question, or do we want to stop here?
We can skip all these now. We've already discussed.
This has already been discussed. DIC discuss कर लो बस और क्या? Because इसमें
Uterine artery embolization, it's not easy.
मैं सुबह उठती मेरे को लूज मोशन शुरू है.
टाइम कम होता है.
हाँ, ये लिखा हुआ आ रहा है कि वो टाइम Zoom meeting time is over.
I think we can stop, Dr. Taru. What do you say?
We will see. Just finishing.
नारियल पानी दे, नारियल पानी दे दो और खिचड़ी बना दो उनको, खिचड़ी दे
केस टू करना है क्या?
You can discuss only
अब मेरे ख्याल से DIC
diagnose.
डिस्कस कर लो. What is, how will you manage DIC? और what is the massive transfusion protocol? ये थोड़ा बहुत सबको आना चाहिए.
मेरे को आपसे पता चला मेरे
She was given uterotonics and intrauterine balloon tamponade was also done. Despite these measures, there was continuous trickling of blood from vagina. She developed hypotension for which she was started on vasopressors, then referred to Tertiary Center Hospital for further management.
कुछ खा लो, lose motion
So
आएगा.
we can very well make out that it was a primary case of atonic PPH, and then due to massive blood loss, a superimposed DIC developed, which is very well known entity, because after massive loss of blood, always the patient lands up into DIC. So we have to start with not only packed RBCs, we have to give fresh frozen plasma as well as platelets in the ratio of 1:1:1 to combat the DIC. And nowadays in our center, we are also using recombinant factor 7A. It acts on the tissue level. It binds with the tissue factors, and then it activates the thrombin. Yeah, and also it
Very
binds
simple.
with.
Dr. Indra, tell me the very simple way कि हमको पता चल जाए कि ये DIC में patient पास हो रही है.
क्या?
मतलब हमारे पास कोई
DIC में
diagnosis
जा रही है
The
patient.
bleeding, there will be generalized oozing throughout, and the blood will be somewhat liquid, blackish liquid. It will the
तो
normal
बार बार
color
टैप
of blood
करके
is
देखो
not
कितनी
there.
देर में क्लॉट हो रहा है नहीं हो
And it
रहा है.
is not, yes, there is
और एक बार
late
मैंने देखा एक
clotting,
पेशेंट की ना
non-clotting.
दांत से ब्लीडिंग हो रही थी, लिप से. तो आई आज सिस्टर की भाई ये क्या है, तो कहती कुछ नहीं मैडम, ये तो बाइट हो गया at the time of delivery, but it was not bite. It was bleeding
Yes,
from gums
the
and the lips.
yeah, आपको है ना जो if the patient is catheterized, there will be hematuria. And you can
hematuria
see
भी
for the
होता है.
color of the hematuria.
Yes,
It is always altered color, blackish color, and the bleeding
अपने
will be.
पेशेंट का hemoglobin करने के लिए अगर निकाला ब्लड तो वो जगह पे बंद नहीं होएगा bleeding.
Yes,
हाँ वो बंद नहीं
every
होगी.
side starts bleeding.
Stitches start
और
bleeding.
एक बार सिजेरियन में कॉवलेयर यूट्रस भी देखा है, बिल्कुल ब्लैक हो गया
Black.
यूट्रस at the time of cesarean.
But
So we have to remove
cochlear
the
uterus is never atonic.
atonic नहीं था, but it was black.
Yes.
And the patient is hypovolemic और उसका वो ड्रॉप हो रहा था, तो फिर फटाफट हिस्टेक्टमी करे. बाद में इन्वेस्टिगेशन हुए ना, कई बार
We have saved many patients with by use of factor 7 because it is available free of cost to us. And
वैसे
one
इसकी
or two,
कॉस्ट कितनी होती है?
it is
2 lakh
around
something?
70,000.
70,000.
Yeah, and one unit or two are sufficient for one patient.
मतलब 1 unit cost 70,000 rupees.
Yeah.
हाँ महंगा आता है बहुत, लेकिन लाइफ
Recommended
सेविंग
dose
कर
जो होती है वो 60 to 19 माइक्रोग्राम पर केजी होती है. तो अराउंड एक इंजेक्शन इज सफिशिएंट फॉर एवरेज फीमेल, पर कई बार हमने 2 भी लगाए हैं.
और
एंड
कितनी देर बाद रिपीट करना चाहिए?
30 मिनट्स.
30 minutes.
So
जैसे इंदिरा जो है ना वो है फैक्टर 7 क्वीन, इसने इतने सारे बचाए महिला में फैक्टर 7 लगा लिया.
हाँ, आपकी भी एक पेशेंट थी.
मेरी भी एक पेशेंट थी.
तो first
फिर
is
फ्री में
massive
लग जाए तो
transmission
क्या
protocol.
होता है?
Yes. You have already told that 1:1 should be given, and we know that within 1 hour 4 units of packed red blood cells should be there, and in 24 hours 10 units of PRBCs can be transfused. So
My one message is there कि at least 4 FFPs have to be given in every PPS patient, क्योंकि generally mild case तो होते ही हैं.
हाँ, तो 4 RBCs हो गए, 4 PRBCs हो गए, 4 FFPs हो गए, and 6 भाई 1:1, usually it is 6, so 6, 6, 6.
platelets.
Usually
One
it
is
is
to one
6,
के
but
ratio में लगाना चाहिए,
at
जितने वो
least
लगाने होते
minimum
वो
4 has to be
हाँ,
given.
यस, मिनिमम इज 4 विद इन। हम जब ट्रांसफ्यूजन के लिए रिक्वेजिशन भेजते हैं तो वी यूजुअली 4 आरबीसीज पीआरबीसीज के लिए भेजते हैं।
Yes.
हम्म।
And this PPS is the only indication for whole blood transfusion. Second is accident. आजकल बाकी तो component therapy is there. Only 2 indications where whole blood is good. यदि कहीं पे है ना ये components नहीं available तो we can very well give whole blood to these patients.
ओके।
क्योंकि उसमें कोगुलेटिंग फैक्टर्स भी होते हैं ना।
हाँ,
उसमें प्लाज्मा सब कुछ है।
प्लाज्मा सब कुछ है।
Only the dreaded complication is anaphylactic reaction.
Reaction, correct.
Yes. So we have to take consent, and to save the patient, we can very well give whole blood to these patients.
Cryoprecipitate, do you transfuse?
Still not transfusing. We have platelets, and we are using platelets, plasma,
Okay.
RBC,
Because
and
that is also very
along with
costly.
that, we are using this factor 7.
Factor 7. So okay.
Yes. In fact, यदि कोई placenta previa वो आ रहा है, उसमें भी we people are using factor 7.
अच्छा।
Okay. And do you think that this is a Ramban for PPH?
No, it is adjuvant, not Ramban. Ramban is
फैक्टर 7 देना है कब डिसाइड करते हो डॉक्टर इंदिरा?
एक्चुअली जैसे हम लोग यदि प्लेसेंटा प्रीविया लेते हैं तो हम उसको पेशेंट को प्री लोड करके ही खोलते हैं बिकॉज वी एक्सपेक्ट पीपीएच इन देम।
तो पहले ही लगा देते हैं फैक्टर 7।
हाँ, क्योंकि जैसे ही वो एक्टिवेट होगा वो इस बीच हम लोग है ना प्लेसेंटा रिमूव कर रहे होते हैं तो जो टिश्यू फैक्टर है वो उस वक्त अवेलेबल हो जाता है टू एक्टिवेट। ये इधर एक्टिवेटेड होता है, टिश्यू फैक्टर एक्टिवेट हो जाता है एंड इट स्टार्ट्स वर्किंग देन एंड देयर ओनली।
एक्रीटा वगैरह में
तो
भी
वो जो है
वैसे
ना,
करोगे तब?
यदि हम बाद में करेंगे ट्रांसफ्यूज तो ऑलरेडी कुछ ब्लीडिंग हो चुकी होती है, इसलिए जो पेशेंट एक्सपेक्टेड है उसमें तो वी प्री लोड जस्ट ओटी टेबल पे लेते ही पहले ये लगा देते हैं फैक्टर 7 एंड देन वी स्टार्ट द सर्जरी।
दिस इज गुड प्रैक्टिस आई थिंक। पर हम
What
लोग प्रैक्टिशनर्स को बहुत ध्यान रखना पड़ता है ना, पेशेंट पे कहाँ करते हैं।
केस ऑफ एक्रीटा?
व्हाट?
एक्रीटा
सेम
पहले लगा दो फैक्टर 7।
हाँ, फैक्टर 7 लगा के देन ओपन।
हाँ, ये अच्छा
ऐसा नहीं,
prevention है।
गैप नहीं, बहुत गैप नहीं होना चाहिए, बट एटलीस्ट है ना जैसे ही हम लोग उसको खोल रहे हैं और जैसे ही
स्पाइनल
टिश्यू
लगाते
फैक्टर
टाइम लगा
रिलीज
दो
हो रहा है, इट शुड बी देयर टू बाइंड विद इट।
ये मतलब
और
अभी तो
आईएम लगाते हैं
कितनी देर पहले? 10 मिनट्स?
हाँ, मतलब जब हम पेशेंट को अंडर कर देते हैं उसके बाद में देन वी गिव इट एंड देन वी स्टार्ट सर्जरी।
आज तो इंदिरा से बहुत सारी चीज सीखने को मिल रही है।
हाँ नहीं सही बात है, लोग तो पूरा ऑब्स्टेट्रिक वो चलाते हैं ना
भाई आईसीयू सेटअप तो इन्हीं लोगों का है ना, दैट्स व्हाई।
और हम पेशेंट भी इन्हीं को रेफर करते हैं अगर हमारा पेशेंट अफोर्ड नहीं कर सकता फैक्टर
सही है।
7 और कुछ भी, क्या करें।
ये फैक्टर 7 के बारे में रिकमेंडेशन
अभी यूट्राइन आर्टरी एम्बोलाइजेशन थोड़ी
नहीं, अभी नहीं है, वी आर ट्राइंग फॉर इट, बातें चल रही है, बिकॉज उसके लिए तो इंटरवेंशनल रेडियोलॉजिस्ट चाहिए होता है और सेटअप चाहिए होता है।
हाँ, सेटअप इन हाउस
अभी तो थोड़ा
इन
टाइम
हाउस
लगता है,
सेटअप
उससे
चाहिए
अच्छा
होता
तो
है।
जल्दी स्टेक्टमी है।
प्राइमी पेशेंट का ही है, अदरवाइज तो चलो ठीक है। प्राइमी
जैसे
पेशेंट
पहले से बात करके 1-2 पेशेंट में कोशिश की थी, बट इन हाउस सेटअप इज रिक्वायर्ड फॉर इट, क्योंकि पेशेंट को वहां भेजना पड़ता है हमको एसएमएस।
नहीं दैट वो उसमें क्रिटिकल पेशेंट सेंडिंग देयर एंड देन वी कांट।
हाँ, so it is not available with us, but
I just
Mahatma Gandhi wale they are doing it.
Taru, I just want to interpret कि it should be already decided कि placenta accreta increta. So why to open if there is an intervention radiology department is there, send there because
Yes,
मैम वो तो है ही बिल्कुल। आप अगर हमको पता है तो हम
मैडम आप
करने नहीं चाहिए।
बिल्कुल सही कह रहे हैं। हम लोग भी ऐसे सेटअप में भेज रहे हैं मैडम वीना मैम, वी आर सेंडिंग द पेशेंट, पर हमारे पास जो क्वालिटी ऑफ पेशेंट आते हैं वो ये कहते हैं कि आपको हमें नहीं पता, हम तो यहीं कराएंगे, आपको जैसे करना
And that
करो।
is okay, but for the life saving, you have to explain कि this is the
Yes,
life
we
saving measure.
explain,
If
we
you
very
go
well
for the
explain। कुछ पेशेंट चले भी
good
जाते हैं,
patients,
कुछ
Recently, last 15 days, we have done the uterine artery blood
Yes,
check.
ma'am.
They said
Rajasthan
it's
hospital
better.
में.
Yes,
Yeah,
in
continuously
Rajasthan hospital
regularly.
you are doing, ma'am, and
यहाँ
in
से
Mahatma
बहुत ज्यादा
Gandhi
होता है
also they are
राजस्थान में।
doing. So we
But
counsel
our
the
most of the
patients.
colleagues, they are bringing Shailja and this. They are happy after doing the. She said, I don't feel any difficulty after doing all this. So there is a personal experience there.
But we
Ma'am,
are
in
also
case-
having those patients who refuse to go anywhere. Then
Okay,
there
that is the
we
personal
are
problem.
left with factor 7 only.
Yeah, that is their personal problem, but we have to explain that this is the life saving.
We are explaining, ma'am, no doubt about it. We tell them that we are not having in-house interventional radiologists. So better you go to some other setup.
You must take the written consent. Now the legal issues are very much there. They said we don't understand. We are not doctors, so you have to take the written consent.
we take a written consent about it.
This is my suggestion. It is okay.
Yes,
Whatever you
ma'am.
have
Yes,
done.
ma'am. Thank you, ma'am.
So अब यहाँ पे एंड कर देते हैं इसको.
Yes, I
37
think,
complete हो गया.
You 4 people are discussing marking. So what are the other points?
So take home message is postpartum hemorrhage remains one of the leading yet largely preventable cause of maternal mortality. The critical determinant of outcome is time delay in recognition and intervention. Can rapidly convert a manageable situation into life-threatening emergency. Hence, rapid recognition, coordination team response, and stepwise escalation of management can save lives. अब केस 3 नहीं अपन डिस्कस कर रहे हैं.
नहीं, I think it was a very fruitful discussion with the panelists, especially Dr. Indra.
Yeah.
Thank you.
Thank you.
इंदिरा यू और
sufficient.
8 and 1 हो रहे थे आप.
Yeah, Indra
अब
is
क्या
sufficient want to discuss everything.
Madam, practically we people are doing so. I was able to respond.
Yeah,
Otherwise,
this is practical experience that is more important than the giving the information about through the books. No,
मैडम इसीलिए हम चार लोग बैठ के डिस्कशन कर रहे थे एक्सपीरियंस के
Yes, that's why I interrupted in between. मैंने कहा अब हो गया बहुत.
एक्चुअली एक प्रॉब्लम बताइए मैम. कई बार क्या होता है कि वैसे तो हमको एसेस कर लेते हैं कि एंटीरियर प्लेसेंटा है, प्रीवियस सिजेरियन है, तो पॉसिबिलिटी ऑफ प्लेसेंटा एक्रीटा है नहीं. सपोज एट टाइम्स पेशेंट कम्स ऐसी कंडीशन में और आपका पहले मालूम ही नहीं है कि इसमें प्लेसेंटा एक्रीटा है, एंड नाउ यू ओपन इट पेशेंट एंड उस समय पता चले कि एक्रीटा है, पेशेंट का इमरजेंसी नहीं हो, तो वापस क्लोज करके भेज दें इंदिरा के पास.
इंदिरा के पास for 57 no.
नहीं तो जब तक आप यूट्रस ओपन नहीं करोगे आपको कैसे पता चलेगा कि एक्रीटा है?
नहीं,
यूट्रस ओपन करने के
कवलियर है ये भाई इंदिरा परक्रीटा.
Didi, time is very precious, you know.
दो
Didi, time is very precious. पहले आप खोलोगे फिर उसको बंद करोगे फिर ट्रांसफर करोगे.
तो भाई पेशेंट अगर स्टेबल है तो किया जा सकता है.
दरुदी मेरे साथ एक बार हो चुका है. प्रीवियस सिजेरियन लो लाइंग प्लेसेंटा 10 सोनोग्राफी, किसी में प्लेसेंटा एक्रीटा नहीं था और मैंने 4 मिनट ब्लड पहले अरेंज कर रखा था. उसको खोला तो प्लेसेंटा एक्रीटा था.
वो परक्रीटा भी कई बार परक्रीटा भी दिख जाता है वो बाहर.
खोलना पड़ा.
But
वो सर्जन था मेरे साथ.
to arrange the blood. Madhulika, the national guidelines said they arrange the 1 unit of blood for each and every cesarean patient. Don't think you have to arrange it all.
तो मैडम
So always arrange the cross match the blood. This is mandatory.
क्रॉस मैच तो करा लो, मतलब पेशेंट का ब्लड मंगाओ बट एटलीस्ट क्रॉस मैच करा.
क्रॉस मैच करा के रखें.
National guidelines है ना, so always keep in your mind cross match always because we can't predict any case.
हाँ मैम, यू आर राइट. हम लोग पहले हम भी सारा को क्रॉस मैच कराते थे, पर हमारे तो ब्लड बैंक वाले बोले इतने इतने पेशेंट का हम नहीं कर सकते.
भाई आपके तो बगल में है ना. हम
हाँ.
हमारे पास जिनके पास ब्लड
आप
बैंक
लोग
नहीं है,
करना चाहिए. आप लोगों करके रखना चाहिए.
Depend upon the person. But the message what we are want to give, we are not discussing the personal problems. We are giving the message to the audience that what to do then. So that
Yes,
is the
we should go for cross match for every patient
So that
before
is the
taking for
message to
surgery.
them. What
क्योंकि पीपीएच का पता किसी का नहीं है, इसीलिए हर पेशेंट में क्रॉस मैच करा रहे.
This is the message to the all the things. Who are listening to these things?
स्पेशली आरएच नेगेटिव है तो जरूर से कराना है.
RH नेगेटिव में 100% कराना है. बाकी ट्राई कि आपका छोटा सेटअप है तो हर पेशेंट का क्रॉस मैच करा के
Every
रखें।
patient. Yes.
Sometimes blood लाना बड़ा मुश्किल है. It takes a lot of time, and the first hours, which is the golden hours, you have missed. That is the important things.
But
Yes.
What we have
one
discussed.
more thing I would like to say कि यदि पॉजिटिव पेशेंट है, क्रॉस मैच का टाइम नहीं है, तो उसको RS नेगेटिव ब्लड दिया जा सकता है, O नेगेटिव
O
ब्लड दिया
negative
जा
दे दो
सकता
ना
है।
बेटा.
Yes.
O negative होने के बाद this is the problem there.
हाँ,
तो
then we
negative
can go
मिलता
for O
कहाँ है? बहुत
negative
मुश्किल
blood.
है।
Yeah.
Yes. So thank you very much, Dr. Taru. I think we can close the session, and thank you, sir. And Dr. MC Patel, sir, is there. Thank you very
Oh,
much.
first big round of applause to learned moderators and all the panelists putting their inputs during panel discussion and expert, making this panel very interesting and informative. So thank you all.
Thank you,
Thank you
sir,
so much.
Thank
for
you,
giving
sir.
us the
All the
chance.
best wishes. हमारी बहुत सारी wishes है sir आपके लिए.
And sir,
Yes.
all
We
the
all are with
best.
you. Dr. Patel,
Thank
we all
you.
are with
Thank
you.
you.
Yes,
Oh
sir.
yes, welcome. Madam.
Yes. Thank you, sir.
Needed.
Nice discussion.
Okay, bye. Good night.
Good night.
Good night.
Good night. Good
I
night.
think we can close the session now.
Oh
Yes.
yes. Oh yes.
Good
Oh,
night,
yes.
everyone.
Good night.
Good night.
Okay. Corona people, we can close.
लेजर से तोड़ते हैं। हाँ, तोड़ते हैं और उसको छोड़ देते हैं, फिर वो निकलता रहता है थोड़ा थोड़ा से। किसका है? कितना बड़ा स्टोन है, कितना बड़ा है? 10 mm तो बड़ा ही है। अगर 7 से कम है तो फिर तो निकल जाएगा दवाइयों से, और नहीं तो उसको करवा लो, तो फिर उसको एडमिट करा दो, करवा दो ऑपरेशन। हाँ हाँ, उज्जवल बंसल है, कोई दिक्कत नहीं। आप रात को आना चाहो तो आ जाओ, एडमिट करके एक बार एंटीबायोटिक वगैरह शुरू कर देंगे, कल 2 बजे कर देगा वो। कहाँ पे पेशेंट, कहाँ पे? अच्छा, जंक्शन में ही रहते हैं। ठीक है, सुबह ले आना, करवा दे। सुबह फिर 10-11 बजे तक ले आना उसको। और कितने दिनों से मालूम है भाई है स्टोन? अच्छा, तो फिर इतना टाइम होता है तो आदमी को दर्द होता है ना, तो दिक्कत आती रहती है। हो जाएगा, कोई दिक्कत नहीं। कर देगा, एक दिन करके भेज देगा। है क्या? क्या कितनी एज कितनी है? अच्छा, ठीक है, तो कोई ज्यादा कोई वो तो होगा नहीं ना, और कोई बीमारी तो नहीं है शुगर वुगर वाली? ठीक है, बस ठीक है, हो जाएगा। हाँ, उनको सुबह सुबह देखना, और आप भी अपना टेस्ट करवा लेना। अच्छा अच्छा अच्छा। अरे रोज रोज आप, एक तो आपका स्लीप अपने आप पूरा सोते नहीं है, तो कहाँ से बीमारियां ठीक हो? हम्म, 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 हम्म। एलर्जी आपको किस चीज से है? अच्छा अच्छा। हम्म, हम्म, अच्छा, गाना रह जाता है। हम्म, हम्म। नए नए बच्चे तो आए हैं बहुत सारे, लेकिन वही बात है। हाँ हाँ हाँ, बस 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 बस। हाँ हाँ। मेरा मेरा जहाँ तक ख्याल है ना, आपको नींद पूरी नहीं आती, स्लीप एपनिया है, आप खराटे ज्यादा लेते हो, बीपी ज्यादा रहता है, डायबिटीज है, थोड़ी बहुत डायबिटीज है ना आपको कि नहीं है? ये सारे मिलकर आपकी एलर्जी एलर्जी को ठीक नहीं होने देते, समझ गए? पहले नहीं थी तो फिर ये ठीक भी तो नहीं हो रही ना, इसलिए नहीं हो रही। पहले दवाइयों तो थोड़ा थोड़ा आपको बूस्ट करती रहती है। हाँ हाँ। हम्म, हम्म, बता रहे थे ना, शायद मुझे तो याद नहीं है क्या बताया। तो लेते रहते हो आप, वो सिट्रीजिन है, वो तो लेते रहते हो, तो लेते रहते हो। बस तो कई लोग तो सारी जिंदगी खाते रहते हैं, एक गोली खाओ और एलर्जी से बचाओ। हम्म, मैं तो बाहर की चीज खाती हूँ और मेरा गला बैठ जाता है। बाहर की चाबी ये तो मेरा गला कैसा बैठा पड़ा है आज। हाँ, गला खराब है, वही पेट खराब, गला खराब, बाहर मिर्च नहीं पचती है बिल्कुल। मिर्च तो बिल्कुल नहीं खाएगा। गंदा तेल बाहर का नहीं खा सकते, तेल तली चीजें सब।
एक दो दिन अभी तो क्या रिकवर हो जाएगा, एक बार ढांचा खत्म हो जाता है तो वो लग जाता है। अब 15 दिन 10 दिन लगते हैं हर एक चीज को ठीक करने में। हम्म। वो तो अपना उससे होता है ना बैक्टीरियल। अभी आपका खाली एलर्जी है, आपका इन्फेक्शन नहीं है। एलर्जी है आपको, एलर्जी जैसे धूल मिट्टी उड़ रही है इससे या तो ये तेल तली चीजों से भी होती है, कई चीजों से होती है। तो इसके लिए आपको, हाँ, आपको कंटिन्यूअसली जो ये गर्मी वाली एनर्जी होती है ना, इसमें आपको कंटिन्यूअस मोंटी एलर्जी लेना ही लेना है। आपको लगातार आपको लेनी है, चाहे आपको गला खराब है कि नहीं है, वो लगातार आप खाओगे तब थोड़ा ठीक हो जाओ। लगातार खाना। हाँ हाँ, उसके बाद भी लेते लेते हैं लोग, उसके बाद भी लोग लगातार लेते हैं। ये एंटीबायोटिक नहीं है, एंटीबायोटिक नहीं है, ये एंटीबायोटिक नहीं। हम्म, हम्म, हम्म। गर्म पानी से गरारे आप करते नहीं, दही छाछ छोड़ते नहीं, ठंडा छोड़ते नहीं। मेरे को ध्यान नहीं। समोसा एक आध को मैं हफ्ते में एक समोसा खा लो, उससे कुछ नहीं होता। हम्म, हम्म। आप ड्रिंक वगैरह भी लेते हो ना? तो ड्रिंक ड्रिंक नहीं लेते? अच्छा, मैंने सोचा आपके जैसे ये लेते हैं ना, ये गुटखा उटखा सब लेते हैं। हम्म, अच्छा अच्छा। अच्छी बात, अच्छी बात, बहुत अच्छी बात, मुझे ये सुन के बहुत खुशी हुई। हम्म, हाँ हाँ, सब लेते हैं आजकल तो, सब लेते हैं। हम्म, हम्म। खा लो क्या, खा लिया करो, ठीक लगता है। ये तो नहीं खाते होगे शालू तो, ये तो नहीं खाते होगे, रोटी तो नहीं खाते ना? अपन तो खुद कभी नहीं खाते। बच्चों के आजकल आदत। आज बार बच गई, मर जाती। और क्या, इतना लूज मोशन आया, 50 लूज मोशन सहने सोखे हैं। तो फिर एक बार दवाई खाएंगे, दवाई खाएंगे तो ही ठीक होंगे ना। अब टिक गया 4 5 बजे, तो धीरे धीरे टिकेगा ना, कोई गंद अंदर चला गया था रात को। पता नहीं है, बाहर खाना वाना, देखो बाहर का खाना घर जैसा तो होता नहीं है। मेरे को मिर्ची से एलर्जी है, और मिर्च वाला काम मिलता ही मिलता है, दूसरा गंदे तेल पल्ले से। अब रात को दीपक ढाबे का, उसको 2 बार बोला, भैया बिना मिर्च के लिया, बिना मिर्च के लिया, नहीं लाते वो। बहुत गंदा, बहुत गंदा, बहुत गंदा। जहर खिलाते हैं, जहर। हाँ, यही यूज कर। उसे तो मोमोज वगैरह खा लो, स्टीम के होते हैं, वो खा लो। अब यार बाहर जाते हैं तो देखा देखी खा लेते हैं, क्या करें। फिर ये दाल दाल की तो बिना मिर्च के नहीं मिलती ना, वो मिर्च मिर्च डाल ही देते हैं। हम्म हम्म हाँ हाँ हाँ, बस 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 बस। हम्म हाँ सही बात। चलो, पनीर पनीर तो बाहर का बिल्कुल। वैसे आजकल पनीर कौन से हैं, सब नकली पनीर है। हम्म 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 हाँ बस ठीक, ओके ओके।
उसका एक शौक ऐसा नहीं है जो मैंने पूरा कर लिया भरोसा रहना चाहिए ना ही मैंने अभी इसका खाली और ना ही कभी हाल ही और ना ही वहीं बैठ के पढ़ा रही
क्या आप कूलिंग से परेशान हैं? हाँ, क्या आपकी गाड़ी में 14 डिग्री कूलिंग है? 14 डिग्री कूलिंग? ट्राई कीजिए। 13 डिग्री कूलिंग। क्या आपकी गाड़ी सिट्रोएन है?
हमारा जो तीसरा गेम है, इस गेम का नाम है बात उठाऊंगी फायर से, बॉल उड़ाऊंगी ड्रायर से। इस गेम को जो भी जीतेंगी वो जीतेंगी एक डबल डोर रेफ्रिजरेटर। शुरू करते हैं अलका जी के साथ में। अलका जी आइए। आइए आपके हस्बैंड आपके साथ आएंगे। क्या आइए अलका जी, आपका समय शुरू होता है अब। नहीं आपसे देख रहा हूँ, मैं कहता हूँ छोड़िए, मैं कहता हूँ डालिए मत, अभी टाइम बचा हुआ है। गई ना वो नहीं मानी जाएगी क्योंकि वो इन्होंने टोपी पहनी भी नहीं थी। अब अपने स्थान पर जाए। थैंक यू वेरी मच सर, आप अपने स्थान पर जाए। थैंक यू। ओके पंडित जी आइए और आपसे खेलने के लिए आइए। आपका टाइम शुरू होता है पंडित जी। आप चलाओ ना नैनों से बाण रे, जान ले लो ना, जान ले लो ना। हमरे बॉडी से आगे आगे आगे। हाँ देखिए आप जान लो। Very nice. आगे 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 पीछे आदि तुम पीछे क्यों हो रहे हो? तुम उधर ही रुको। अब जाएगा बराबर। ये देखो ये डालने का ट्रिक उन लोगों को बताइए। पेटीएम जी इसको बता दीजिए 500। आपने अकाउंट तो खोला। ओके इसके बाद में आएंगी किसी को बुला लें। आ जाओ। कौन खेलना फिर आ जाओ आपके साथ में। आपका टाइम शुरू होता है अब। पहले बैलेंस तो करो यार, बैलेंस नहीं कर रहा वहाँ पे। स्टडी
मैंने ऐसा तो नहीं कहा था।
Seven, 6, 5, 4, 3, 2, 1. Time off. That's it. Thank you. तो देखिए आपका स्कोर कितना है? आगे भी लिखिए आप। इस समय सबसे आगे आप कर रही हैं। सिर्फ एक बची है, वो है कोमल जी आपका है, और कोमल जी आप यहाँ पर आए। कोमलता से खेलिएगा। आपका समय शुरू होता है अब। आइए डायरेक्टर ऊपर लेके जाइए, ऊपर लेके जाइए। थोड़ा नीचे झुकना पड़ेगा अपने को। इसके ऊपर जगह पे इतना पीछे आना। ऊपर लेके जाए, ऊपर तक ऊपर तक जाए। ये गया डालिए अंदर। आगे आगे जल्दी 7 सेकंड है 7 सेकंड है 7 8 नीचे 7 आज चारों ने तय किया कि हम ना हाथ को स्टडी नहीं रखेंगे, हम फड़फड़ाहट से दूर नहीं भागेंगे। दूर कितना है? 2 यानी कि दीप्ति जी जीती है राउंड। दीप्ति जी सिर्फ ये डबल डोर रेफ्रिजरेटर आपने नहीं जीता, आपने जीते हैं 40 सुनहरे सिक्के भी। तो मैनी कांग्रेचुलेशंस। प्लीज जाकर अपना फ्रिज ले लें, क्योंकि ये गेम आपका अपनी डॉट ने भी जितवाया, तो आप ही जाए। अगर आपने ऐसा क्या जादू किया अपनी सास के ऊपर कि आज आप अपनी सास की सांस हैं?
मैंने कोई जादू किया नहीं, बस मेरा जादू चल गया है।
क्या सबसे अच्छी बात लगती है आपको अलका जी के बारे में?
कोई भी बात बोलो तो उल्टा जवाब नहीं देती है, मतलब हर काम करती है, टाइम पे उठती है, सब।
और सासू क्या चाहिए? सारा काम कर लेती है, टाइम पर उठती है,
बॉडी मसाज सब कुछ।
बॉडी मसाज। तो सास क्यों नहीं खुश होगी? आपकी अपेक्षाएं थी कुछ अपनी बहू से?
जो चीज सब मिली उनके अंदर।
आपको लगता है कि आपको ससुराल में ज्यादा प्यार मिला?
जी। अब कहीं ना कहीं मैं बिहार से बिलोंग करती हूँ, और मैं बिहार में एक ऐसे गांव से हूँ जहाँ पे ऐसी लड़कियां होती है जो कुर्ती के नीचे जींस वेयर कर सकती हैं और विदाउट दुपट्टा, पर वहां पे है कि आप कुर्ती के नीचे जींस भी नहीं पहन सकते। इफ अगर दुपट्टा भी ले रहे हैं तो गले में लिए ना आपको पूरा फैला के लेना है, बाल बांध के रखना है, नो लिपस्टिक मेकअप किए तो लगता है संजय सिंह की बेटी हाथ से निकल गई है, बहुत पैर आ गया है इसके, लोगों की तरह तरह की बातें। और मेरे मॉम डैड कहीं ना कहीं वो उसी माहौल में रह रहे, तो उनकी भी मेंटेलिटी वैसी ही हो जाएगी। तो आप यकीन नहीं मानोगे, जब मैं 9th क्लास में थी, मुझे स्कूल जाना पड़ता था तो अपने पेरेंट्स से परमिशन लेना पड़ता था। मुझे स्कूल जाने के भी लिए नहीं मिलता था, मुझे मॉम डैड से परमिशन लेने के। सबके माँ बाप ऐसे होते हैं कि अपने बच्चों को स्कूल भेजते हैं, उनका एजुकेशन इंपॉर्टेंट है, वो लाइफ में कुछ करे, पर मेरे माँ बाप ऐसे नहीं कि तुम घर में रहो, रोटी बनाओ, सब्जी बनाओ, घर का काम करो। मैं उस चीजों से बहुत फ्रस्ट्रेट होती थी, क्योंकि मेरे बहुत सारे कजन थे कि तुम गांव में रहते हो, स्कूल नहीं जाते हो, गवार कपड़े वैसे, ये चीजें मेरे को बहुत ट्रॉमा देती रहती थी कि यार मैं कैसे जगह पे आऊंगी। मेरे मॉम डैड तो बहुत अच्छे हैं, बट ये छोटी छोटी चीजों के लिए परमिशन लेना। और अभी भी मेरे साथ बहुत टाइम ऐसा भी होता है कि मेरे इंग्लिश वीक है, चीजें नहीं हो पाती, तो लोग उसमें मुझे चढ़ाते रहते गवार कहेंगे, पर मेरा एजुकेशन कभी वैसा हुआ ही नहीं है। मुझे याद है कि जब मैं 9th क्लास में थी, जब मुझे स्कूल जाने नहीं देते थे, तभी मेरे डैड ने मेरी शादी फिक्स करवा दी थी एक लड़की से। उस टाइम पे मैं 14 या 15 साल की होंगी। मेरे पापा ने मुझे लिटरली रोज जितने टॉर्चर करने चाहिए एक इंसान ऐसे जानवर को जैसे टॉर्चर किया था, उतनी मेरे साथ बहुत दिन हुआ था। ऐसा लगे कि मैं सुसाइड करूं, मेरे को जिंदा ही नहीं रहना। मैं थोड़ी सी जिद्दी टाइप हूँ कि अगर आपको जो करना है करो, पर मैंने जो ठान लिया मैं वही करूंगी। इसके लिए मुझे मरना पड़ेगा, मेरा लॉस हो, आई डोंट केयर, मेरा ऐसा रहता है। बट वो मैंने जिद पूरा किया। मेरी मॉम ने मेरी मासली घर पे 3-4 महीने के लिए शिफ्ट करा दिया। उसके डैड भी थोड़े दिमाग से है, ये भी ऐसी है, तो इसको ले जाऊंगी तो कुछ हो जाएगा।
सपोर्ट सिस्टम आपकी मम्मी थी आपके साथ?
मम्मी नॉट सपोर्ट सिस्टम, बट मम्मी का ऐसा था कि हस्बैंड भी उनकी, डॉटर भी उनके, तो कुछ तो करना पड़ेगा, बीच का सोल्यूशन निकालना पड़ेगा। बट मम्मी का भी ऐसा था कि शादी कर लो, 21 के एज में तुम तीनों भाई बहन हो गए थे, मेरी शादी होगी, अब तुम्हारा क्या, तुमने जो भी करना चाहिए था किया। मतलब मैं यहाँ तक आई हूँ, मैंने जो भी मैंने काम किए, मैं ये नहीं बोलूंगी मैं बहुत बड़े काम किए, पर मैंने जितने भी काम किए ना, मुझे खुद पे गर्व है।
आपके लिए ससुराल में क्या बनना?
मेरे लिए जैसे कि हमेशा से बचपन से जिस दौर से मैं गुजरी हूँ, मेरे माँ बाप कोई भी चीजों के लिए मना करते थे, हर चीज के लिए। पर ससुराल में कोई भी प्रॉब्लम नहीं थी। तुम्हें शूट करना है, तुम्हें जैसे कपड़े पहना है, तुम्हें फ्रेंड के साथ पार्टी करना है, मस्ती करना है, जो करना है, तुम्हारे हस्बैंड को पसंद आ रही है, तुम्हें अच्छे लगे, बात खत्म। दुनिया क्या बोलती है, भाड़ में जा। मुझे ये ससुराल से फ्रीडम मिला, और मैं आई थिंक, मुझे लगता है कि कोई बोलेगा ससुराल वालों की शिकायत करेगा, मैं ऐसी पहली इंसान होंगी कि जो, मुझे कोई फर्क नहीं पड़ता। मुझे लगता है कि बेस्ट है मेरे सबसे ज्यादा ससुराल वाले, इससे ज्यादा किसी के ससुराल वाले बेस्ट हो ही नहीं सकते। पिछले जन्म का कुछ हमारा कर्मा होगा जो कुछ साल के लिए मुझे वहां पे डाला, देन उसके बाद मैं अपने रॉयल घर में आ गई।
चलिए मैं उम्मीद करता हूँ ये हमेशा ऐसा बना रहे, इससे बेटर हो, बेटर से भी बेटर हो।
हर एपिसोड में आप अपनी सास के बारे में बताते हैं।
अरे यार मैं बहुत मार पड़ती है उसके बाद में।
कि आप अपनी सास को फोन करें और हम
ये जेल इसलिए होगा मैं। अभी सच्ची ये रिस्क वाला मामला ये आसान नहीं है। वीडियो कॉल करने वाला। मीना जी आप क्या करती हैं?
मैं डिलीवरी करता हूँ। मेरी बेटी 1 महीने की थी ना, मैं इधर मुंबई आई, रात दिन एक कर दी, उसका एक शौक ऐसा नहीं जो मैंने पूरा ना किया। आई लव यू। और तो अपने ऊपर भरोसा रहना चाहिए, ना ही मैंने अभी हिम्मत हारी और ना ही कभी हार, ना ही हम बेटी को हार नहीं।
इंडियन आइडल के मंच पर सुखविंदर सिंह का जबरदस्त जलवा।
इंग्लैंड का दिल फिर से टूटेगा, दिखाएंगे टीम इंडिया के धनुष। लाइव में देखिए नेटवर्क के टीवी चैनल्स पर।
होम मेकर बने हर चीज सुपरस्टार। तो देखते हैं हमारे साथ खेल रहे विनिंग सुपरस्टार्स के नाम। ये रहे टॉप 10 विनिंग सुपरस्टार।
अजीत सर, एक सवाल था मेरा।
प्लीज।
हमने सारे एपिसोड्स देखे और हर एपिसोड में आप अपनी सास के बारे में बताते हैं।
अरे यार बहुत मार पड़ती है उसके बाद में।
और आप ये बताते हैं कि आपकी सास आपको दामाद ही बोलती है, बेटा नहीं बोलती है, तो हम भी चाहते हैं कि आप अपनी सास को फोन करें और हम
मेरी सास एक बार मैंने अपनी वाइफ को फोन किया था, तो उसके बाद जब मैं जांच करी थी, अपनी सास को फोन करूंगा तो ये जेल इसलिए होगा मैं। अगर मैं सास को फोन तो करता है। ये ना रिस्क वाला मामला नहीं, अली सच्ची ये रिस्क वाला मामला, ये आसान नहीं है। और वीडियो कॉल करने वाला इसको एडिट नहीं और क्या नाली बड़ी तो एडिट काम चीजें क्या कितने दामाद हैं अभी तो बिना बताए अपनी सास को फोन करने की हिम्मत रखते हैं। नहीं मेरा फोन है यहाँ पे, उसमें नेटवर्क पता नहीं होगा किसी ओके, ऑल द बेस्ट आप सबको मेरे साथ का। हेलो अमित जी नमस्ते। हेलो अमित जी नमस्ते। अमित जी नमस्ते। राजीव बोल रहा हूँ क्या नमस्ते, थोड़ा सा धीरे से बोलो ना, इस समय बहुत लोग सुन रहे हैं आपको। नहीं प्लीज मैं क्या करूँ, लेकिन हो आप अभी सबने बोला कि अपनी सास से बात करके दिखाओ, सबकी सास से अपनी सास से बात करके दिखाओ। मैं ब्रिगेडियर हूँ, मैं कुछ करता हूँ। बोलो ना कुछ तो, क्या बोलो, कैसी हो आप? क्या कर रही हो? कुछ नहीं, अपना तुम्हारे को भी क्या मिलता है यार, आप बहुत लोग आपको सुन रहे हैं, आप देखती हो कि इसके ऊपर मैं आपकी आपका काफी नाम लेता हूँ, मैंने आपका नाम काफी रोशन किया है, पर दिल से तो सच्चाई ये है कि आप जानती हो कि आप बच्चे मैं मोदी हूँ, मेरी मम्मी नहीं है आप जानती हो, लेकिन मैं अपनी मम्मी आप में देखता हूँ। और नहीं मैं और मैत्री के लिए आप बहुत महत्व रखती हो, आप जानती हो कि मैं दिल से आपको इतना प्यार करता हूँ, और मैं आपको ये कहना चाहता हूँ कि हम खुश हैं क्योंकि तुम हो ना। कितने नंबर दोगे आप 10 में से? 10 में से 10। अरे झूठ बोल रही है, काफी करते थे 5 दिन देती किसी को। ये सच है क्योंकि ये सब सुन रहे हैं यहाँ पे, इसलिए कि हम दोनों के दोनों टीवी पर इसलिए बोला आपने मुझे कुछ देर के काफी पीछे भी बोलती सब कुछ क्या होता है सब अच्छे में। आपको बोलूंगा रिकॉर्ड करके रखे जब आप इसे तारीफ करती हैं। अंकल के सामने भी नहीं बोलती, तो किसके सामने बोलती हो कि नहीं बोलती हो? मेरी 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 साइड के लोगों के सामने मुझसे पूछा था यहाँ पे कि ना मैं आपको आप मुझे बोलती है दामाद जी आप मुझे बेटा नहीं बोलती, हालांकि मैं तो आपको मम्मी जी बोलता हूँ। आप भी आंटी जी बोलते हो। अरे आंटी जी मैं वैसे आंटी बोलता हूँ, लेकिन आप जानते हो जब फोन करता हूँ तो मम्मी जी बोलता हूँ, अभी मैंने बोला मम्मी जी। नहीं पता है, मैं वैसे भी दामाद जी बोलते हूँ, लेकिन आपको बेटा ही मानती हूँ ना। हाँ में क्या होता है, हमारे घर में जब जाते हैं ना तो मेरी जो सास है तो पहले मुझे पता है वो स्टार्टिंग में होता है कि अच्छा ठीक है, उसके बाद जब मैं जाता हूँ किचन में तो मैं कभी प्याज काट रहा होता हूँ, कुछ काट रहा होता हूँ या कुछ और कर रहा होता हूँ, एक इत्मीनान से बैठती है, ये कभी इस चीज को नहीं लेती है कि दामाद आए घर में तो चलो कुछ स्पेशल करो। आई थिंक ये रिश्ता है जिसकी वजह से हम लोग थोड़ा कंफर्टेबल। मम्मी जी थैंक यू वेरी मच, इससे पहले की आवाज सच्चाई और बोलो, मैं रख रहा हूँ, थैंक यू वेरी मच। आज जो इस एपिसोड में शुरुआत में मैंने सवाल उठाए थे, मुझे ऐसा लगता है कि उन सवालों के बारे में अगर हम बातचीत भी शुरू करते हैं तो मुझे लगता है कि हमारे रिश्ते, हमारा देश और हमारा समाज कहीं ज्यादा बेहतर हो जाएगा अगर सिर्फ हम बातचीत शुरू कर दें। चलिए आगे बढ़ते हैं, मैं बताता हूँ आपको आज का स्कोर क्या है, किसके पास कितना है। अलका जी के पास में है सुनहरे सिक्के, अरे क्यों मुझ पे छुपा रही है? अमिताभ जी के पास में 30 नए सिक्के, लेकिन इतना सारा सोना और सोने जैसा हस्बैंड और दुनिया के साथ उनके पास है। ओमा जी के पास में है 40 नए सिक्के, लेकिन उनके साथ में अब है उनके पापा जी का सपोर्ट, उनके पिता का सपोर्ट। एक जी के पास में है 65 सुनहरे सिक्के और एक बहुत ही सुनहरा भविष्य। आपकी बेटी इतनी काबिल है, आप खुद अपने पैरों पर खड़ी, आपने जिंदगी को बदला, तो आप भी बहुत धन्यवाद है और आपका भविष्य बहुत बहुत खूबसूरत हो, ऐसा हम सब कामना करते हैं। जी के पास में है ऑफकोर्स अपने माँ बाप का प्यार, प्यारे से हस्बैंड और बहुत प्यारी सी बेटी, लेकिन उसके साथ साथ में इनके पास में है 70 सुनहरे सिक्के। आज इस दिन नाम की सेवा बढ़ाएंगी पंडित जी आए प्लीज।
मिले हो तुम हमको बड़े नसीबों से। 4 से 5 साल से मैंने इंडियन आइडल ऑडिशन दिए हैं। मेरे हस्बैंड और हम लोग हमेशा लाइन में जो भीड़ रहती थी उसमें सब खड़े रहते थे।
नेहा जी, आज हमारे शो पर ना एक लेडी आई है जो इतनी बड़ी फैन है।
मुझे सच में ऐसा लग रहा है कि मेरा सपना पूरा हो गया है आपके साथ बात करके। मैं ऑनलाइन डिलीवरी करके आती हूँ। मैं सुबह में 6 बजे जाती हूँ, रात को 2 बजे आती हूँ।
ये आपने जो काम करना शुरू किया, जरूरत क्यों महसूस हुई आपको?
जब मेरी शादी हुई थी ना, मतलब मेरी लव मैरिज हुई थी, उसके गांव में मैं गई ना प्रेग्नेंट थी, तो वो बहुत बुरी तरीके से मारता था। कितनी लड़कियां हैं जो फांसी लगा के मर जाती है, ऐसा सब होने के बाद में, पर मेरे अंदर इतनी हिम्मत है ना, मैं अपनी बेटी को भी ऐसा बनाना चाहती हूँ। अगर उससे कुछ परेशानी आए ना, ऐसा अभी हिम्मत हारी और ना ही कभी हारूंगी और ना ही अपनी बेटी को हार में दूंगी।
नमस्कार, आदाब। क्राइम पेट्रोल डायल 100 के सिटी क्राइम्स अध्याय में आप सबका स्वागत है। 4000 शहरों और कस्बों से बना है हिंदुस्तान, जिसमें से 19 महानगर ऐसे हैं जो देश की उन्नति में बड़ा योगदान करते हैं, और इन्हीं में से एक महानगर है देश की राजधानी दिल्ली। साल 2007 से साल 2016 तक दिल्ली में 83% अपराध बढ़ा है। देश के 40% महिलाओं के खिलाफ होने वाले अपराध अकेले दिल्ली में ही होते हैं। दिल्ली में औसतन हर 1 घंटे में 4 बलात्कार के मामले सामने आते हैं, और हर साल ये आंकड़े बढ़ते जा रहे हैं। दिल्ली डरी हुई है, दिल्ली सहमी हुई है, और अब इस खौफ के साए में एक और जिंदगी आने वाली थी।
सरकार का क्या रोल है? मॉडल ही बच्चों के सरकार क्या मुश्किल या कोई
जीतने वाले को कभी ये नहीं पूछा जाता है कि उसने जीतने के लिए सच का सहारा लिया था या झूठ का। मायने रखती है आखिर चीज।
कैसे काम
झूठे इल्जाम ऐसा हिटलर कहता था।